about 20 seconds. Test 1 2. Test 1 2.
but historically had low rates of heroin use. Women, people with higher income, and people with private insurance. Nearly all heroin users report using another drug in addition in the past year. 2 out of 3 use at least 3 drugs. Cocaine continues to be commonly used alongside heroin, but we've also found a startling increase, 130%, among people using heroin and prescription opioids without a medical reason. Our data
Test 1, 2. Test 1, 2.
Excellent. All right. Okay, everyone, we're gonna go ahead and begin the meeting. I'd like to start by thanking everyone for taking the time to be here today, and for all of those at home or at work who may be tuning in over the live stream. We appreciate you taking the time to listen to us all at the commission. We have a great lineup today that I'm sure everyone's excited to hear from. And so with that, we're going to begin. My name is Danielle McGrath. This is full commission meeting. I took over for Sean Kiefer, who transitioned out of the governor's office I am now Deputy Chief of Staff over Executive Branch Agencies, and so delighted to be chair here today, as well as working with Chief Justice and other commission members. I'd like to just thank all of you for your hard work on behalf of the governor. This commission is extraordinarily important, and so from the service that you're giving here to your dedication to children, we could not be doing this without you, and it shows in everything that you do. I was grateful enough and pleased to go ahead and read the annual report. I found it to be extraordinarily thorough. For anyone who hasn't had an opportunity to read it yet, highly recommend that you do so. It's comprehensive. It shows a number of different things that the commission has done, among them pulling people together, not only at the state level, but national stakeholders. We've had many of our task forces here from a variety of different folks that are helping educate on what's going on in this arena. They've also encouraged conversations. Not only are they hearing from folks, they're actually having dialogue about public policy issues to best inform this commission and others. And last but not least, they're actually putting these items into action. And for that, the state of Indiana is better because of it. So with that said, now that's a little bit about me and my background. I'd like to go ahead and just have all the other commission members introduce themselves, that those viewing from away and those in the audience know who's representing the commission, where everyone is from, and then also how long you've been with the commission. So Senator Holdman, would you mind beginning?
Sure. Travis Holdman, Indiana Senate. I've been with the commission since its inception. Northeast Indiana, by the way.
Brian Bailey, Budget Director for Governor Pitt. I've been with the commission since the beginning.
Parts of Madison and Delaware County, and I've been with the commission since its inception as well.
Susan Lightfoot, and I represent probation for the state of Indiana, and I'm from Newcastle, Indiana, and have been with the commission since its inception.
I'm the Indiana State Health Commissioner, and I've been with the commission since I took over my job in October, and I
Good morning, Dr. John Warnert. I am the Secretary of FSSA. I've been on the commission 14 months.
Lilia Judson, Executive Director of State Court Administration, and I have been with the commission.
Larry Landis, Executive Director, Indiana Public Defender Council, from the beginning.
Dave Powell, Executive Director, Indiana Prosecuting Attorneys Council. I've been around as long as Larry has. Greg Zeller, Indiana Attorney General. Anyway, I was
Mary Beth Bonaventura. I'm the Director of the Department of Child Services, and I too have been here from the beginning.
Loretta Rush, Indiana Supreme Court, from the beginning and probably maybe before the beginning, along with Director Bonaventura. And then I want to thank the members. These are long meetings. They've been 3 and 4 hours, and there have been almost total attendance. So when you say you've been here since the beginning, there's been a lot of hours that these individuals have day jobs. So I need to thank you all for the attendance. And it's been 90+% total attendance.
Thank you, everyone, for taking the time to introduce yourselves. I'd like to go ahead and move on to our next agenda item, which is approval of the May 20th minutes. Does everyone have a copy of those in their pamphlets? Yes? Move. Do I have a second? All of those in favor say aye. 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 The minutes are approved. Thank you. All right, so next on the agenda, we are here to hear from Dr. Tim Kelly. Dr. Kelly, we are very excited to hear from you about the substance abuse crisis in Indiana from the physician's perspective. If you'd like to come to the podium. Thank you very much. Please feel free to begin.
Thank you. It's very much a privilege and honor to be here and speak to such an impressive group. I'm not sure I've ever had an opportunity to talk to people who make policies and allocate resources and drive, important decisions related to mental health and addiction. So I was told one of my topics was why do people use drugs or something, and I'm going to try to touch on topics that I think are current and pertinent that will help you as you look at this issue. I've provided materials to you. I have a little folder of materials I actually give to patients. So if you know people that are struggling with these problems, feel free to disseminate those to whoever might benefit. And there's a copy of my PowerPoint in your materials. So I'm from this community, and so I'm invested in this community. I was born in Lafayette. I went to St. Joan of Arc Grade School at 42nd and Central. I went to Brebeuf High School. I went to Indiana University in Bloomington. I went to IU Medical School. I'm sort of boring. I keep staying in Indiana for the most part. I did live in Colorado for a year. I did my residency in internal medicine at Methodist Hospital, and I've been practicing at Community North most recently, and I've been a medical director of an addiction treatment hospital in the past. I very much like what I do and would like to be available to any of you at any time. So I want to start with a little question. Raise your hand if you feel comfortable, if you know someone, a close relative or friend who's battled an addiction in their, okay. So we have almost everyone raising a hand. Raise your hand again if you know someone who's had reasonable success in battling their addiction. Okay, so we just established two things. This condition is common, and this condition is treatable. So with that, we'll start here. So I just called this Addiction 101. So I know this is the Children's Commission, so I wanted to point out that 1/4 of all children in the United States are exposed to alcohol or drug abuse or dependence within their family's immediate environment. So problematic use of alcohol and drugs in the home is linked with poor school performance, delinquency, child neglect, divorce, homelessness, violence, and abuse. Up to 80% of incidents of domestic violence are associated with alcohol. Currently, every 25 minutes, so at least once during this presentation, someone will die from an opiate overdose. And in 2008, the lines crossed and opiate overdose began to exceed motor vehicle accident as a cause of death in Indiana. And a number of other states, that's true as well. In 3 years ago, 259 million prescriptions were written for opioids, enough to provide a bottle to every adult in the U.S. Approximately 80% or more of opioids in the world are consumed in the United States, and we have 5% of the world's people. Over 90% of hydrocodone is consumed in the United States, and that's the #1 opioid of abuse on the streets. 2 million people are now addicted to painkillers, over 500,000 people addicted to heroin. 1/3 of Americans say addiction is caused by a deficiency of willpower or self-control. I hope at the end of my talk no one is subscribing to that theory. 1 in every 12 high school seniors reported non-medical use of hydrocodone in the past year. 1 in 20 reported OxyContin use. This is not how you want to make USA Today, but this is how we made USA Today. Injection drug abuse has fueled an outbreak of HIV in rural Indiana, especially Scott County, I believe. Nationwide surge in hepatitis C, a recent surge in Madison County, I've been made aware. Increase in numbers of babies born that have to undergo sort of a detox process from drugs. And there are not enough doctors to provide substance abuse treatment. One interesting stat, the governor of Vermont, I don't even know who it is or what party he's in, but he, in one of his major addresses, he said, I'm doubling the budget. I'm attacking full-force substance abuse. I'm going after it. Young people are dying. And they're not bad people, they're good kids. I tell patients, you know, you're a good person with a bad disease, not a bad person. So the governor of Vermont announced he was doubling the budget. So all of a sudden there was more money. And there was no deficiency of patients because he recognized the epidemic. What they found out was there was not enough providers to provide the treatment. So they begged a young and reputable doctor to provide treatment in one of the more populous areas where they were having a lot of problems. And at first he said, oh, please, that sounds like a root canal. Don't do that to me. I don't want to treat substance abuse. I got a busy family practice, it's growing. And they begged him, and he said, it's a public health emergency, please. He said, okay, I'll give you like 3 hours of my week. And he later said, this was on NPR radio or something, it later became his favorite afternoon of the week to see these kids and see their lives turn around and things like that. So addiction is costing us $468 billion a year, and roughly 2 cents of that is going to prevention, treatment, treatment or prevention. Much of it's going to locking people up and various other collateral damage of addiction. And I know in the past we've had various initiatives to intercept drugs and stop drugs from coming in the country. I don't know a single one of my patients that's ever had trouble getting drugs. So the efforts to treat the supply side maybe ought to shift more towards the demand side, is my thought. Maybe because I'm on the demand side of the treatment side. Okay, so treatment is cost effective, $4 to $7. Our treatment invested saves $4 to $7 in drug-related crimes, criminal justice courts, thefts. Hamilton County saw a tripling of property crimes, petty theft, property damage. Substance abuse treatment is a really good idea for taxpayers, but it shouldn't have to be. We should do it out of humanity. Dr. Humphreys of Stanford University. So what is addiction? Addiction is a primary chronic illness like hypertension, diabetes, asthma, schizophrenia that has multiple determinants. So do other chronic illnesses. Diabetes, for example, type 2 diabetes is by far the most common form of diabetes, over 90%. And the two main risk factors are family history, genetics, and being overweight. By far, those are the two biggest contributing factors, and we're in an epidemic of that at the moment, too. So addiction is like that. 40 to 60% of the cause of addiction is DNA. And that's been proven in adoption studies. So what they've done is they've taken people who have a documented strong biological family history of addiction, adopted at birth, never see those people, raised in families where there is no addiction. Then you have to follow these people for a long period of time and see if they develop addiction and compare the rate of addiction in that group to the known rate in the general population. And what do you think the difference is? It's 4 times higher in the group that is adopted, not raised around addiction, and their only connection to addiction is DNA. So roughly half the cause of addiction. So addiction often happens to vulnerable people who have it's sort of like the gun is loaded and something pulls the trigger, is one way to look at it. So anyway, this is a primary chronic illness with genetic, psychological, environmental factors contributing to its development. It's often progressive and fatal, characterized by impaired control, preoccupation, compulsive behavior, adverse consequences, and distorted thinking. So if you want to know more about what happens in the brain, you know those sort of curvy, that outer surface of the brain there? That's called the cerebral cortex. That's what does a calculus problem and came up with amazing treatments for HIV and cancer and put somebody on the moon. That's the thinking, calculating, problem-solving part of your brain. This other part down in here is in a more primitive part of our brain. It has, so there's a pathway in your brain. When I talk to patients, I tell them it's the reward pathway or the fun pathway. Okay, everything in the brain has a biological rhyme and reason. And the rhyme and reason of this is to reinforce behaviors that have to do with survival, eating, drinking, sleeping, sexual behavior. So the brain reinforces those behaviors by making them pleasurable in this area of the brain. The two main structures are called the ventral tegmental area and the nucleus accumbens. Okay, all drugs that have addictive potential or create highs or euphoria activate this pathway. And they often do it in a much more powerful way than the natural behaviors for which it was designed. So the common denominator in the acute effects of drugs of abuse is activation of this pathway. The primary neurotransmitter involved that's being enhanced is dopamine. So the lesion, if you want to call it that, neurophysiologic abnormality and addiction, is in this brain reward pathway, and I show this slide for one reason, the word hijacked. Thus, the basis of the disease of addiction involves hijacking of this pathway, this normal pathway, such that it drives addictive behaviors along with or instead of adaptive eating and sexual behavior. For alcoholics and addicts, the resulting craving and impulses to drink make it difficult to avoid using. So this part of the brain in addiction is hijacked. So, so we said the causes, genetics, early onset, people who start using substances at an early age are at much higher risk, potentially 5 times higher. The brain is developing into the mid to late 20s. Your brain does not stop developing in high school or even college. So most people's brain is continuing to evolve or develop into their mid to late 20s. If you expose the developing brain to drugs, and the earlier you do it, the more you alter brain development and create susceptibility. So drug addiction manifests as a compulsive drive to take a drug in the face of adverse consequences. So if you really had to boil this down to 2 hallmarks, one is this impaired control. So the person who uses, say, alcohol, if that's their drug of choice, when they drink, one way to say this to patients is that they can't predict what's going to happen when they pick up a drink. And it can be very confusing to the person because people have different patterns. Some people drink every day. Some people binge drink. Some people had a sort of a explosive onset to their addiction in adolescence. Others take years and years and don't develop addiction until their 50s, 60s, and 70s. But that's true of other diseases. You can get diabetes when you're 2. You can get diabetes when you're 80. So this is often viewed by some people as a bad choice or a moral failure. So we have much more knowledge now about the drug effect on the brain and the modulatory role of genetics development and these other factors. This should result in improved treatment and improved outcomes. So one of my questions was, why do people use drugs? So here's part of it. Young people. I call this the adolescent perfect storm. They are very curious. Weren't we all curious? Didn't we all take a few risks that were probably extremely poorly advised? I would be at the top of that list. Peer pressure, and so adolescents are highly sensitive to peer pressure. They often lack confidence. If they feel pressured to do something or to fit in, they have a very difficult time. And the lower their self-esteem, the greater susceptibility they seem to have. Let's see. So addicted individuals suffer from a progressive functional and structural disruption of certain brain regions that we just, resulting in impairment in motivation, reward, inhibitory control. All right, so normal adolescents, I call one of the adolescent mindsets bulletproof. The average adolescent, if he drives his car 100 miles an hour, he does not think he's going to be the one that's going to crash and die. Now, we know they do it all the time, but they actually think that they can drive a car 100 miles an hour and they're not going to die. Okay, and so they do all kinds of risky things. And it actually some of this has to do with their brain itself. So some of this risk-taking and novelty-seeking and sensitivity to peer pressure is because the brain is not developed so that executive function and motivation and various other, insight and judgment are not optimal in adolescence. So, I'm sure you've had this thought before, like it sort of takes a certain degree of luck just to get through adolescence, not to mention good parenting and the proper environment and all kinds of other ingredients that help an adolescent become a responsible and productive person who potentially leaves the planet in a better place at some point, okay? But adolescents, they're bulletproof. They don't even understand mortality. I mean, they don't relate to mortality. Not to mention that they're highly susceptible to peer pressure. So they have this perfect storm. So, so those are some of the issues for young people. So what do you do about this? So we've talked about what addiction is. We talked some of the hallmarks, impaired control, and continuing to use in the face of adverse consequence. So you can have a problem with a substance. You could make a bad decision. I could be my 21st birthday, I could go out, I could get drunk because my friends are badgering me, I could get in a car, I could get a DUI. Am I an alcoholic? Well, of course not necessarily. But if I don't have a problem, I can successfully modify my behavior. That's classic human learning. If you get bitten by a dog, you have a heightened awareness or vigilance of dogs because you've been bitten by one, so you're very careful. That's part of human learning. That's actually our main adaptive advantage on planet Earth, is our ability to learn and adapt. So anyway, so addiction is very powerful because it's overriding that fundamental, that basic survival mechanism. You know, we're not as far as an organism, we don't turn colors to mimic our environment. We don't have the biggest teeth. We're not the strongest. We're not the biggest. We're not the fastest. We don't fly through the air. We don't come out at night. What do? We just have this thing between our ears that allows us to learn and adapt. And addiction is so powerful, it overrides that so that people are still using in the face of adverse consequences that would deter a normal person. So what do you do about this? So I call the disease of addiction an 800-pound gorilla. And much of what I see as treatment is a pop gun. So I'm not a fan of pop guns. And I figure people don't come to me for help, so I can give them a pop gun, so I try not to. So patients with substance use disorder, this is a quote from Dr. Catherine Bradley. She is a teacher, highly respected expert in addiction. I believe at the University of Washington, has written a textbook, teaches psychiatry and addiction medicine. Patients with substance use disorders receive poorer quality care than patients with any other common chronic condition. Most patients do not receive treatment, and medications are particularly underutilized. We'll visit that topic a little bit more. Patient-centered care and decision-making are essential for high-quality mental health and substance use disorder treatments. 4 counseling approaches have been shown to be effective with people with addiction problems: cognitive behavioral, behavioral couples therapy, 12-step facilitation, and motivational enhancement. So actually, patients don't always fit one thing. So every diabetic, if you refer someone to an addiction treatment program and you notice everybody gets this exact same thing, like a sausage link coming out of a machine, it's not a good program. Because if you sent someone to a doctor for diabetes, they shouldn't have an identical treatment. Okay, so some of the issues with addiction treatment, it's sort of developed outside mainstream medicine, the 30-day program, the Minnesota model it was called. And people would go, 30 years ago, and it's still, people would go to a 30-day program or go to rehab, and they were expected to never use for the rest of their life. Sort of like it was pneumonia or an acute illness. It's not acute illness. It's a chronic relapsing condition that's highly treatable. So it's more like diabetes, hypertension, schizophrenia, that really needs long-term care, not just punctuated episodes of acute care. So managed care got involved, and they said this stuff is sort of too expensive and this 30-day stuff is crazy. So they started sort of going the other direction, and I saw a program recently on CBS, and they presented a guy they called Dr. Denial, and he just denied all the care. He was with a very prominent insurance company, and he just denied care. Unless you were going to die today, you didn't meet his criteria. So that's a problem. Some states have more progressive laws and prevent insurance companies from having unilateral control over this, and Pennsylvania would be an example of that. And then early in my career, we used to have like the AA people, and then you had people that were more like biological, wanted to use medication, and if you put them in the same room, they'd kill each other. But now they're starting to realize that medication and AA and various tools of recovery are compatible and complementary and not necessarily antagonistic. Okay, so what are some of the challenges? We need more doctors and nurses. I have a young man here, Dr. Patrick King. He came with me today. He's a second-year family medicine resident at Community Hospital. He came voluntarily. He's my tech support in case I mess up this computer. Among these other guys are fabulous too. And I think it's great that young doctors want to make an impact in this area. He's interested in pain management, but he wants to know much more about addiction so he doesn't get blindsided by people who have addiction problems. Now, so I'm encouraged but we need so many more people like Dr. King. So here we have a pyramid. This is the new way of sort of looking at addiction. It used to be alcohol abuse was sort of poor judgment with alcohol, and then alcohol dependence was the illness with impaired control and use in the face of adverse consequences, compulsive and preoccupation, and distorted thinking. So the patients historically that I've taken care of are up at the top of the pyramid. They're the most severe. At the bottom of the pyramid are people who are just starting to do things like college binge drinking and hazardous use of alcohol, and then So we now are looking at it as a continuum. And you want to prevent the people who are down here from going up here. So the chronic care model, if you ever want to know more about this, a very impressive man, Dr. Thomas McClellan, he was the assistant drug czar for the United States, or OLMD, whatever that is, Office of Drug Control Policy. He was the assistant to the director, and he's for years has been at the University of Pennsylvania. He talks about chronic disease management. So rather than providing reactive acute care episodes in an expensive hospital setting, chronic care management or model is proactive, more innovative, more effective, and it mirrors the disease more, just like diabetes management. You don't go to a 30-day diabetes program. You get a diabetic doctor, you learn self-care, you check in with people. So much of it is teaching and supporting and motivating self-care. All right, so here's my little thing I hand to almost every patient I deal with. I tell people that you need to buy into, if you possibly can, as many tools on this list, this is in your material, that you possibly can. So I call this the kitchen sink, or instead of the pop gun, this is the bazooka, if you will. Okay? So there's research from doctors and nurses programs that, and you're familiar that almost every state, including Indiana, has an Indiana State Nurses Assistance Program, an Indiana State Physician Assistance Program, a Dentist Assistance Program, and a Veterinary Assistance Program. For healthcare professionals who actually suffer from this disease, do you kick them out of the profession because they could be a potential problem in the event of a relapse and harm an innocent patient? Or do you not monitor them at all? So the answer, the in-between answer is you make them highly accountable, and they have to call phone numbers every single day to see when their drug test is, and they have to follow, it's all monitored tightly. And it's very well done, and so you preserve the professional and protect the public at the same time. So accountability is a very big thing. People on probation, that's a form of accountability, if the people are adequately monitored. Medications, if you have alcohol, opiate, or nicotine dependence, medications raise the success rate. I wouldn't say it's always miraculous, but it's across the board. If you have those three dependencies, and you go to a program for addiction, and they don't bring up medication, you just went to a substandard program. They at least should be bringing it up. The success rate for opiate addiction, right here, no matter what is hanging over your head, loss of your kids, loss of your license, loss of everything, 10% or less. And I know people are, this is widely debated, and I hear all kinds of uninformed opinions, trading one thing for another, and there's four medications for alcohol, there's 3 medications for opiates, and there's 3 medications or pharmacologic interventions for nicotine. I'm a huge fan of AA, NA, and this is the 80th anniversary of AA, 12-step programs. Almost everybody can ride a bicycle to one. They're free. They can provide a lot of support and understanding. I can go on and on. That could be a whole nother session. Counseling programs, of course, people need to learn coping skills and get intensive help. Many people have, in fact, in many hospitals and many programs and agencies, coexisting mental health problems are the rule, not the exception. So we call that dual diagnosis when they have, or there's comorbidities. They'll have many people. Addiction is more common in people with mental health disorders. It goes both ways, and mental health disorders are more common in people with addiction. Lifestyle changes, quit smoking. That's another whole topic. I spend a ton of time on smoking. Indiana is not, we've historically, this is pretty bad, we've been in the top 3 states for smoking for a long time. I don't know where we are exactly, but Kentucky, West Virginia, and Indiana have been the top 3 states for smoking. So smoking is a weird addiction. It doesn't get you fired usually. It doesn't get you arrested. It doesn't get you divorced. It just has this one terrible side effect called premature death. Okay, and 18% of people in the United States smoke. What's interesting, if you have another addiction like alcohol or pain pills or cocaine, it's well over 80%. So smoking is a really good marker if you're a doctor and people come to you wanting pain medicine. If they smoke, they already have the disease of addiction and they're at increased risk. A lot of doctors don't pay attention to that. Okay, so service work, spirituality, these are the tools. I say, try to get all of these things in your corner if you can. And your program does not have to look like everybody else's. Okay, perfect storm. How did we get into this prescription drug epidemic? Okay, well, liberalization of opioid therapy. Doctors were criticized. Pain became the fifth vital sign. Dr. Portnoy and Associates in New York said that doctors had opiophobia, they called it. We were afraid of these drugs that could vastly improve patients and their pain. Newer, more potent, smorgasbord of choices, demands on primary care, move the meat, see the patients, don't sit there and go for hours explaining why this is not a good treatment. Societal attitudes, want the easy fix, all the drug commercials, like take this drug and won't have erectile dysfunction, take this drug and you won't have a headache, take this drug and you won't have depression, so the sort of the quick fix. Parents and healthcare providers often naive. Healthcare providers were told addiction is rare. Dr. Portnoy said the rate of addiction in a chronic pain population treated with opiates was under 1%. He has since retracted that statement on the cover of the Wall Street Journal. It's actually 35 times higher than that. Minimal screening and evaluation for addiction. So what are red flags? If you're a doctor or you're a health provider, what should you be looking for? Smoking. Family, we just said it's a genetic disease largely. Family history of addiction, personal history of substance abuse. You would not believe the number of patients. This is what I do all day long. I see patients, I pull up the pharmacy inspect report. They have red flags coming out their ears off this list, and they're on triple controlled substances. I saw a lady in the past 2 weeks, if you're on 100 milliequivalent milligrams of morphine, your risk for a bad outcome is 9 times everybody else. 100. This lady was on 2,900 milliequivalents of morphine. Milligram equivalents, 2,900. It was enough to kill Noblesville, much less her. She was chasing her husband with a knife before she went in the hospital.
I was going to back you up on the training on the pain management and the fifth vital sign. Isn't that still being taught?
Yeah, and there's another problem is that now doctors are all worried about these HCAP scores and patient satisfaction ratings, and they're all worried that if they don't give people pain medicine, they're going to be written up, and then they're going to be demoted and have their compensation reduced. It's absolutely crazy. So yes, it's still, I mean, hospitals have become, there's competition in hospital systems, and hospitals are keenly aware of, their satisfaction scores, and actually Medicare demands those. And so if I'm a drug seeker, and the only reason I'm at the hospital is to get drugs, and you can't remove people from these scores either. Because I was going to ask the hospital, there's an article in the New England Journal by a woman psychiatrist out of Stanford, and the title of the article was, "Why do doctors prescribe opioids to known opioid abusers?" And part of it is this overwhelming pressure of patient satisfaction and this emphasis on pain, and the smiley face and the not so smiley face and the frowny face and all that stuff. And the doctors feel like a little bit, not a little bit, a lot in the rock and the hard place. So when you go to the ER, if I'm a pain drug seeker, I'm an addict, I go to the ER, I'm rocking. I mean, the doctors can tell, they have a sixth sense for this. If you worked in an ER, the patient's rocking on the bed, and the doctor walks in, nicotine is reeking from his jacket. He says his back, he fell, and he's had a back fusion, and he fell, and the doctor knows why he's there, and the patient waited 3 hours to get in, and if the patient doesn't get some pain pills, he can even make a scene and start calling people names. They get agitated because you waited 4 hours and now you're not going to get anything. So what they always do is the same thing. They give you a 10 or 15 Vicodin just so you won't make a scene. You maybe won't write them up, because then the doctor has to write a book to answer that, okay? Because he'll get the complaint, and then he'll have to write a book saying okay, I actually was respectful to this patient. He's just mad because he didn't get opiates. I never called them names. I never raised my voice. I just, anyway, I think you probably know the story. So see, these are some of the red flags. Having a psychiatric condition or personality disorder is a risk factor. Personal history, family history. Here's a big one. I wish doctors would not do this. Patient insists on being on multiple classes of controlled substances. Opiates and benzos is my pet peeve. You must be on Xanax and Vicodin or Klonopin and morphine or Valium and Percocets. It's unbelievable. Allergic or can't tolerate or not interested in non-addictive medicines or approaches or treatments like physical therapy. Patient always in chaos, never seems to get better. Reports or appearance of intoxication always must have a higher dose. This is one area when something doesn't work, the patient's always a 10. I've had patients that are going into a coma and you can barely talk and they say their pain is a 10. How do you treat that? By pushing them more into the coma? Multi-sourcing, poor reliability, poor family support, etc. Okay, so I got a lot of this information. I'm not a pain specialist. So I had to learn about pain management, and this is how it's approached at the Cleveland Clinic. If you don't assess all 4 of these areas up front when you first treat a patient who potentially may think he needs strong pain medication, all areas will fall apart in the end. You must assess addiction, their medical condition, chronic pain, and their psychiatric status. If you do not assess those, the wheels tend to come off. Why use opiates in the first place? To improve function. Function is the gold standard. Symptoms are okay, but function is the gold standard. And I see this all the time. People pay attention to symptoms and not function. So I see totally non-functional person. This morning, before I got here, I saw a young lady, not even 30 years old. And she is on a controlled substance, pain medicine. She spends 16 hours a day in bed. She quit her job because she didn't think she could do it. It was too hard. She was drinking 9 to 10 drinks a day, and her doctor's prescribing to her. And her function is just, and she's suicidal and was going to kill herself, which is how she got in the hospital, and has tried that twice before. And she's in her 20s, and she has to be on narcotics. So, I mean, it's very sad. Okay, so here's another thing that's important to know, that they've studied function and quality of life, and with regard to patients on strong opioids, lower or weak opioids, and no opioids. And the people who take no opioids for chronic pain have the highest function and the highest quality of life, and strong opioids have the lowest quality of life and lowest function. Now, so back to my other pet peeve, the pet peeve I mentioned, do not combine sedatives and opiates. Why? Because it causes cognitive impairment, depression of mood. And another thing is that people get on these benzodiazepine drugs like Xanax, and they take them for decades. I've been collecting some materials recently, doing research on this. There's some very limited benefit in taking, if any. In fact, you get more side effects when some people think the benefit is almost gone after 6 months if you take it every single day. They work fabulous for like people that can't get on an airplane. They work best when you don't have to take them every day. So you're not so tolerant to them. When you take them every day, just like opiates, you get tolerant and you lose a lot of the therapeutic benefit. In fact, a report out of England is now reporting chronic benzos as having a doubled increased risk of dementia. So I've been telling patients that, so like keep taking your benzos and, welcome to Miller's Mary Manor here shortly, So cognitive impairment, depression of mood, falls, these are all associated with people who have to combine opiates and benzos. There's too many downers for the human brain. To improve outcome and lower liability, develop guidelines, learn to screen. This was the problem. There was no screening. I showed you those 4 circles and those red flags. If doctors would screen up front, they could realize who's going to blindside them. Okay, so establish an upper limit, be firm, and have your response rehearsed. I often make guidelines, the bad guy. Patient will say like, oh, I really got to be on that Xanax and morphine and Somas. And I say like, well, gosh darn it, you know what, I got to follow the guidelines. And I follow the guidelines at the Cleveland Clinic, and they are totally against that. So I really can't do that. So if you have a response that you can make to this, use written care agreements, keep track of red flags, consider controlled substance medications a trial if you're even going to do it, try to make it short term. Okay, so statewide prescription monitoring systems, use those, stop chronic opiates in response to red flags, trust your instincts. Let's talk about heroin. Okay, heroin. Heroin is actually a trade name of a pharmaceutical product, in case you didn't know that. Like Prozac is to Lilly's, heroin was to the Bayer Corporation. In the 1870s, you could go into a pharmacy in Germany and you could get heroin. And what was its claim to fame? It was going to be a non-addictive alternative to morphine. But some scientists who didn't work for Bayer found out that heroin, whose real name is diacetylmorphine, becomes morphine. So how could it be a non-addictive alternative to morphine when it's metabolized to morphine? So heroin is what's called a prodrug. That means heroin itself, diacetylmorphine, is not even active. It doesn't do anything. It has to be metabolized, and the first metabolite is MAM, monoacetylmorphine, and the second metabolite is morphine. So the next two metabolites are active, and the parent drug is not active. So these are just little examples of heroin on the street. It's incredibly accessible now. It is dirt cheap. Over the last 4 to 5 years, heroin death rates are markedly increased. The demographics of heroin addiction have changed dramatically. It's now in Carmel High School, probably Brebeuf Cathedral, Zionsville, Noblesville. It's everywhere. And it's not, and there was a nice special about this on CBS where they showed a group of mothers from Naperville, Illinois. Naperville is an upscale suburb of Chicago, and the mothers had one thing, and they showed their neighborhood. They were all $500,000 homes. These were all attorneys, judges, accountants, nurses, dentists, and the mothers had one thing in common in this little support group. They'd all lost a kid to heroin, and they all came from this wonderful little neighborhood, and their kids played Little League Baseball and were paper boys and choir boys. They were good kids. They didn't look like bikers and, you know, the hardcore that, or whatever you would associate with a former stereotype of heroin. Now it's these kids, and they're naive. They don't know what they're getting into. So CDC considers prescription drug addiction an epidemic. I'm going to try to show a little very short clip at the end. Opioids, it's off the wall. Indiana ranks 17th, so we just made it right about the top third of overdoses, and overdoses always parallel prescribing amounts. We had one doctor in the state of Indiana, and I'm sure Mr. Zeller may have had something to do with this, but he prescribed 93, he's no longer in practice, fortunately. His overdose deaths were in double digits, and he wrote 93,000 prescriptions in a 3-year period. One doctor. He saw 100 patients a day. It was like a conveyor belt. That's what we call a pill mill. Florida had the worst problem. So reasons for the epidemic, I think we talked about this is for the heroin epidemic. Doctors not trained in addiction, and then it's tied to prescription pads, you know, how heroin is incredibly cheap, crackdown on pill mills, new law and spec system, newer drugs more difficult to inject sometimes. Opiates, people who have opiate addiction, if you ever talk to an opiate addict and say, like, what do you see in this? Because, you know, I've taken a pain pill, it didn't do anything for me. There's sort of what's called genetic, there's heterogeneity of the opiate system. So that some people, when they take opiates, get euphoria. And they feel like they have, like, huge energy. You have to think of the opiate system as an excitatory system or an inhibitory system. And some people have a predominantly inhibitory system, so when they take opiates, they actually get tired or sedated. It controls pain, they get constipated. Some people, when they take an opiate, it acts more like speed. And this is probably genetically determined. When they take an opiate, they have like overwhelming confidence, energy, euphoria, and they're just wired this way. And it's highly reinforcing. And then, so they get sucked into it, and then what happens is they develop tolerance. In the end, they're using only to avoid withdrawal. All the euphoria is mostly or entirely gone, and they're now using to avoid withdrawal. So there's so many people out there, as we speak, addicted to opiates, who would love to quit. In fact, I see them all the time, and they've tried to kill themselves. They hate this life, but when they try to quit, they get sick. So this is probably a little bit too technical, but this shows that opiates come in 3 sort of categories. Agonists, those are the things people like to use on the street. Those turn on the system all the way. Then there's a partial agonist group that sort of that turns on the system, but not as much as the group on the right, but it also has some blocking properties. And then the group on the left are total antagonists. So they like put a manhole cover on an opiate receptor. That's how I explain it to patients. So if you take an antagonist, that's what naloxone is. It wakes people up. This group has the highest affinity for opiate receptors. So if you're overdosed on heroin and you take this group, it kicks the heroin off the receptor and blocks it. This group turns it on and has almost no blocking property. So this has the highest affinity in blocking. This has the most intrinsic activity, is the phrase. Okay? And then the middle group is sort of a hybrid. So treatment. So medication-assisted treatment for opiate addiction is now the standard of care because I told you that the success rate is under 10%. So there's 3 treatments. Historically, the oldest by far is methadone. Rockefeller University, 1960s or 70s, Dr. Neiswander and Dole tried to treat street heroin addicts in New York. They found dismal results. They get them all detoxed. They were relatively comfortable. They get them off the heroin, and then 10% stayed clean. So they experimented with different approaches, and they tried methadone, and the methadone patients did better if you look at several parameters. Passing drug tests, not committing crimes, staying in the program, and not transmitting diseases. So people who take a drug for opiate addiction do demonstrate higher rates of compliance, staying in treatment, passing drug tests, not doing illegal things, and not passing diseases. Okay, so there's 3 treatments. We said methadone was the first. I've never done methadone treatment. It's not my favorite of the 3, but all 3 are better than nothing, than no medication. All 3 are better than no medication. Buprenorphine, also known as a trade name that most people know it by as Suboxone, is a safer drug than methadone in the event of an overdose. It was found in Europe. It is in that group of partial agonists. And then naltrexone is a total blocker, a 30-day injection. Now, a lot of people really like this one because the first 2 have potential for abuse. And in methadone clinics, they give it out every day. In Suboxone, you go to a provider and you don't get it every day from someone who's supervising it. So that can be a problem for some patients who are not super motivated, or their providers are not really tightly monitoring everything. Now, naltrexone has no abuse potential, no withdrawal, no euphoria, but you have to be completely detoxed off of opiates to be on naltrexone. But all 3 reduce cravings for opiates. Anyway, so I'm an advocate. Remember my list, the tools of recovery. I'm an advocate for anything that improves the outcome. And these are never standalone treatments. They should never be. And too much of it is that sometimes, where you see people getting, say, buprenorphine, and the requirements for counseling and recovery are minimal. So I just tell, these are actually to support your brain while you get busy and learn the other ways of thinking and behaving that then can make you independently capable of managing your recovery. So it's a win-win if you're a treatment program. You increase recovery rates and better outcomes, and your program has more patients because they don't all drop out. Who supports this? The World Health Organization does, United Nations, Hazelden, the Cleveland Clinic, American Society of Addiction Medicine. Hazelden is the bastion of AA, and they support medication-assisted treatment because they know the success rate is so dismal, under 10%. And a lot of people are sort of on a high horse. They'll say like, oh, we'd never stoop to doing that. But they don't, then if they're going to do that, they should be honest and put a sign on their wall that says we have a 10% success rate. I never see that sign though. Okay.
I have a question on 30-day.
It depends on the population, but it's probably at least triple or,
For all 3 or individually? What's the difference between?
Okay, that still is not entirely known. They have not done enough like head-to-head things. They really work for different populations. For example, injectable naltrexone really requires, I think that it's often used in healthcare professionals who have to go back into a hospital to work where they diverted drugs or something like that. It's really for more motivated people. So nobody totally knows. They're probably very comparable. Now one problem is that some of it's easier to drop out of treatment with naltrexone because it's not as easy to drop out with buprenorphine or methadone because you will have withdrawal symptoms if you try to drop out. Most people, including the top people, this was a big controversy in my field. How long should people be on these treatments? And so I talked to people that I had really high respect for that are the leaders in this field. One was Dr. Thomas Costin, who's the endowed chair of psychiatry and addiction medicine at Baylor University and was at Yale before that. And Dr. Michael Miller, who's been the past president of my organization, American Society of Addiction Medicine. They both say 1.5 to 2 years, that it takes that long for these people to establish the behaviors and thinking patterns of recovery over the behaviors and thinking patterns of active addiction. But I think that the outcomes are actually sort of comparable, but they're much higher. And if you're
30%, 40%?
I'd say 40 to 50%. Okay, so the first few weeks following detoxification are the most, it also depends on, if we could get people to buy into doing it by the standard of care, it would make a big difference. So for example, if I were to treat a patient with buprenorphine, I want family involvement and I want accountability. If I have a heroin patient, I don't just give them that. I say, you bring in, and I want to see the whites of their eyes. You bring in your mother, father, brother, somebody that I can see that is reliable and who's willing to lock it up in a lockbox and watch it go under your, so I sort of create that mechanism they have in the methadone clinic. We have to come in every day. I try to create that so that, actually, there's a drug called Antabuse that you're maybe familiar with, disulfiram. It's used for alcohol. If you take it and you drink, you get sick, and some court systems use it. I do the same thing. Okay, so that drug's been studied. It's totally ineffective without an accountability program, a spouse or a probation department administering it. When it's given under observation, it becomes much more effective. So I try to do that with buprenorphine. And then, so it really, if we would follow all the standards of care, I believe it would be 50%. Okay, so the first few weeks following detox are the most dangerous because people are highly prone to relapse and overdose and death. So some programs who detox people to nothing, you can make a case that it's malpractice and a dangerous procedure because these people are now highly vulnerable to overdose. So they go to jail, they get out and overdose. 60% of fatal overdoses occur when you've gotten clean for a short period of time and the patients forget they don't have the tolerance anymore. So it's imperative that these medications be considered. Addiction is a treatable disease and extremely common. We established that here today. We are in an epidemic. If you can't relate to people with addiction, just think of something that you have tried a million times to start doing or stop doing, okay? And then you can relate to addiction. This is something that really attracted me, addiction. When one person gets better, 5 or 6 people you never meet will get better. I really like that. Many people will not get better because they are not having access to what I consider the bazooka versus the pop gun, okay? And in Illinois, I heard this yesterday, Chicago is now leading the country in emergency visits for overdose. Emergency department treatments for overdose. Chicago's leading the country, and since 2007, they've cut their budget 30%. Vermont, the governor doubled the budget. He doubled the budget. So Chicago is now number 48 on this list of states that are financially supporting addiction treatment, even though their major city is leading the country in overdose episodes. So I'm hoping we're going towards Vermont, not towards Illinois. All right, lastly, this is like 3 or 4 minutes. Now I need the tech gurus. This is Dr. Thomas Frieden. He is the director of the Center of Disease Control in Atlanta.
As a physician, I'm alarmed by our latest research on heroin trends. Between 2002 and 2013, heroin use went up by more than 60%. Tragically, the heroin death rate also increased by nearly 300%. Heroin abuse is highest among males, non-Hispanic whites, people with low incomes, people without insurance and not enrolled in Medicaid, and those living in large urban areas. But researchers found big increases in groups who have historically had low rates of heroin use: women, people with higher income, and people with private insurance. Nearly all heroin users report using another drug in addition in the past year. 2 out of 3 used at least 3 drugs. Cocaine continues to be commonly used alongside heroin, but we also found a startling increase, 130%, among people using heroin and prescription opioids without a medical reason. Our data show that people who are abusing or dependent on prescription opioids are 40 times more likely to be abusing or dependent on heroin. There's been speculation that the decrease in inappropriate opioid prescribing is driving people to abuse drugs such as heroin more. And while for some individuals this may have happened, the data strongly suggests that that's not the primary driver of the heroin increase. Heroin is cheaper, more potent, and more available than it has been in the past. Just like alcohol and cigarettes, when heroin is cheap and readily available, people are more likely to use it. Clinicians have an important role in reversing this troubling trend in heroin abuse. We need to talk with our patients about the serious risks of taking prescription opioids. These risks include both addiction as well as overdose and death. We need to remind our patients of other pain treatment options that may be more appropriate for their condition and less likely to lead them down a terrible pathway. Prescription opioids are powerful and highly addictive. It's critical that providers follow best practices for prescribing. Providers should use their state's prescription drug monitoring program to identify patients who might be misusing prescription drugs. If a patient hasn't previously received an opioid, consider all options before prescribing them. Even for severe pain, physical therapy, non-steroidal medications, acetaminophen, local measures such as warmth and ice, and realistic expectations about the time to recovery can make a big difference. Giving a patient an opiate medication for the first time is a momentous decision. Other than for patients with intractable terminal pain for conditions such as advanced cancer, this should only be done if other options fail. For patients already struggling with heroin addiction, it's imperative that they have access to effective medication-assisted treatment. This includes methadone, buprenorphine, or naltrexone, and counseling and behavioral therapies. Medication-assisted treatment has been shown to improve social functioning and reduce risky behaviors that transmit infectious diseases such as HIV and hepatitis C. Heroin use is increasing across nearly all populations, and there's a strong connection to prescription opioid abuse. Bottom line, it's our job to prescribe prescription opiates responsibly, identify patients who might be misusing them, and support those addicted to prescription opioids or heroin with medication-assisted treatment.
Okay, that was my last slide or whatever. So at this point, I'll stop and answer any questions. Yes, Greg.
You know, back to your point about early onset, kind of developmental. If we look at the neonatal abstinence syndrome, the increase in babies being born addicted, are there any studies that show us what that's going to result in later in life?
Well, you know, they're already born to an addict.
Yeah.
So they're right out of the gate, their risk is 4 times higher than the general population. Even if that child is taken away from that mother, never sees that mother again. You know, and I don't know the answer exactly, like how much more it would increase risk over the already high genetic risk to have gone through. That's crossed my mind before. I'll see if I can find out more about that.
Well, my concern is that we are going down this path of we don't want to label children. So, you know, between the Department of Education and everybody else, we don't want to label children. But on the other hand, if they have, you know, been exposed in the womb of, you know, opioids, maybe there should be at least some medical tracking so we know high propensities of addiction or whatever problems that might manifest.
Right. You know, there's so many red flags that we could latch onto to improve identification of people at risk. And certain ethnic groups are, like my ethnic group, the 2 leading ethnic groups that have seemingly like higher concentration of addiction risk. One is the Irish and the other is the Native Americans. And in Ireland, they used to have a group, they used to have a little organization called the Pioneers. And they would try to get young people to like say, I'm not going to drink alcohol. You know, because yeah, I suppose you don't miss what you never try. But the risk in some families in Ireland and in Native Americans is just astronomical. Because you know the majority of the people in certain families are addicted. So you can almost pencil it in for some of these people. So you really, you know, in your point about, you know, developmental and like smoking is, one time if I got appointed like the drug czar of a high school and said, you need to find out, your job is to find out who's using drugs. My very first thing, I just find out who smoked first. That's, you know, low-hanging fruit. They're already addicted, they're smoke. I had to talk one time to a class of a high school, and they had a group of kids that all had a chemical addiction, and I asked them I asked them to raise their hand if they smoked. 90%, this was high school kids, 90% of these kids smoked. And you know, but you're absolutely right about the developmental risk and changing your brain. If you want to read more about that, Nora Volkow, who's the director of NIDA, she is very much interested in these developmental issues.
Attorney General, to your point, we've asked that question before too, and one of the problems is we don't even have a uniform definition of neonatal abstinence syndrome, first and foremost. But so far, the medical data out there suggests, as Dr. Kelly mentioned, that the risk is more related to the genetic predisposition. Your mother was an addict, so you're going to be more likely to be an addict. And the environment, if you go back home to that environment where your mother became an addict, you're going to be likely to become an addict. And that's a more important indicator, it seems, both of those two, than the fact that you were exposed in utero. And so then the question is, are we going to somehow label everyone who exist in that environment, whether they were an NAS baby or not? And so it's an interesting discussion to have. I actually had a question either for Mr. Moore or for Dr. Werner, and perhaps you can weigh in on this also. There is confusion in the state about coverage for MAT, for methadone, for Suboxone, and for Vivitrol. Methadone, I know, is only covered for chronic pain by Medicaid, but can you both speak on Vivitrol and on Suboxone and whether it's covered or not? Or can someone speak, and maybe you can speak on what doctors in the community are saying and whether they're having frustrations getting it covered?
Well, yeah, the confusion around methadone is that for methadone maintenance, that's a federal program, requires a federal license, and that's the delivery of methadone. We don't pay for that through Medicaid. We do pay for the 10 milligram methadone tablets for pain, and up to 60 milligrams is covered without prior authorization. Above that, based on last year's law, there's some prior auth around that. The Vivitrol, Suboxone, those are fully covered. We've never denied or tried to prior authorize a Vivitrol prescription. The problem, of course, is who's prescribing it and are they prescribing it appropriately? The price tag on these particular compounds is, it's very expensive. I mean, it's very expensive not to use them for the potential outcome, but we're also concerned that they shouldn't be prescribed indiscriminately. For example, in a lot of jails or emergency rooms, they just want to use Vivitrol on patients that haven't been detoxed appropriately. So they're not even prepared to deal with the acute withdrawal syndromes that they're going to deal with. But again, it's an education problem. It's perceived that, well, we just put somebody on Vivitrol, it's a shot and it'll last a month. So if they haven't been detoxed, it's probably not a good idea to do that.
And Suboxone is covered?
In Subutex.
Had a comment and a question. Dr. Hill, I thank you very much. I love the approach, the broad continuum approach to treatment, and very supportive of that. I mean, you and others have done a great job outlining the scope of the issue, the flags, and kind of where we are currently with addiction. But just like in Vermont, all the identification leads back to the same choke point in the funnel, is access to care and qualified providers. So I'm thrilled that the physician is with you today to learn more and interested in addiction in terms of his role in the future with internal medicine and yours as well. My question, I think the challenge that we have at the division as well as across the state is, what about addiction counselors, social workers that get no addiction training in their degree, from that level all the way up through addiction psychiatrists and physicians who specialize in addiction. That level of training and access to care is going to continue to be critical. There's a role for technology to play, but that doesn't substitute 100% for that face-to-face. So kind of your...
I agree. I have a question. I had this experience that probably had a very big impact on me. I was at the end of my first year of medical school. I needed a summer job, and I was sort of procrastinating, and my parents were saying, like, you need to pay for part of your medical school. What are you going to do for your summer job? So I found out at the last minute I could apply for this grant, and the grant paid me to learn. It came from the Department of Mental Health and Addiction, and the grant paid me to learn about addiction, and I got paid $5 an hour. I mean, that would probably be $50. But I got paid $5 an hour, and it was like an 8 or 10 week program, and I applied very late, and they said there's a chance you won't get it because you applied so late. So I waited a week, and they called me back and said, good news, bad news. Good news is you got it. Bad news is you have to go to Terre Haute and live in Terre Haute for this program. So anyway, they put me in a detox center. I got a bed in the detox center. That was where I lived. Anyway, that sort of changed my, also coming from an Irish family, there's a few little addiction issues in my family tree, and there was positive outcome in my family tree. Okay, so that experience of being paid to learn about addiction, I believe, really helped me. So what if we started incentivizing people, you know, and sometimes the carrot doesn't have to be giant, but what if we started, and I've been talking to my young colleague over here, Dr. King, who's from an interesting town. The name of his hometown is Bad Axe, A-X, Michigan. Anyway, why can't we incentivize guys to do what Dr. King is doing? You know, he's tagging along with me. He's learning so that he won't get blindsided, he won't contribute to this problem. Because I don't know of any other field of medicine where doctors butcher the patients would be better not going to the doctor in many cases because they come out worse. How many fields are like that? Is cardiology like that? Is pulmonary like that? Is everything like that where you get worse when you go to the doctor? I mean, we see this all the time. That's why I spend my whole day on this. So I think we need to incentivize doctors and mental health centers. Like, for example, I can think of 2 mental health centers locally, and a third is coming online where they're doing medication-assisted treatment for opiate addiction. But I can think of at least 3 others that aren't. So if you go to one, what if you're unlucky and you go to one, you're going to get the 10% success rate, okay, for opiate addiction at these other places. What if, and this is where it's way beyond my expertise, what if there was some way to incentivize these places to ramp up the training, you know, you get, I don't know, I mean, this would be, can we incentivize, and people do, like what if you paid a bonus of $5,000 to a family doctor to go into, like the doctor in Vermont that was thinking it was a root canal, became his favorite afternoon of the week. What if we paid a $5,000 bonus for a doctor and he agreed to take 2 hours a week or 3 hours a week of addiction clinic, and he could use Vivitrol, he could use buprenorphine, he could do smoking cessation, he could do any kind of addiction medication-assisted treatment when it's appropriate, and get fully trained, and he would get incentivized financially to do that. Then we could ramp up the capacity, because you know the concept really now is medical home and population management, and keeping people in the mainstream of primary care. And addiction was outside the mainstream, and so the doctors don't. I know it's a problem when I see good doctors doing dumb stuff. You know, I know their reputation as a good doctor, but then I see them giving Xanax and Vicodin to the same patient. Like, I cringe. I know it's not good treatment, but they're generally good doctors. It means they weren't trained.
Correct. Thank you.
Excellent. Let me ask, you know, giving the legislators a little bit of credit, they did produce a program to incentivize, and actually some of the monies that we received from cases against pharmaceutical companies with off-label marketing. So we did something on that. But at the last prescription drug symposium that we held, there were these nurse practitioners that would come up and say, you know, we have a plan to eventually get more help. But today, we have these people that present. We know they're addicted. We know it's going to be weeks before they get in to see anyone. Why can't I do something better than just send them out on the streets waiting to get in? So we've got this crisis right now, and all of the answers are for later when people are educated and we have new doctors in the field. Right now we've got this crisis, and they're not looking to see what would be better in the future. They want some answers right now from the medical community.
Greg, a lot of these people are treating addiction. They're just doing it with the pop gun instead of the bazooka. Okay, so I mean, they're assessing people. They have some training in addiction, and understanding how to use Vivitrol or how to use medicines for alcohol, of which topiramate, naltrexone, acamprosate, and disulfiram, 4 medications for alcohol. You wouldn't have to go back for 4 years or drop out of your practice to learn how to, you know, use medicine for alcohol, use naltrexone for opiate addiction. You could go to weekend seminars. In fact, the buprenorphine training, probably one of the problems is you can get certified. It takes about 5 hours. You can do it on your computer. You don't have to go to a fancy hotel and go to a conference. You can get certified on your computer. It takes about 4 or 5 hours. And then you get a waiver and you have a number. Here's one problem. I've been doing addiction work for over 30 years, and I'm board certified in it, and I'd hate to, I mean, the hours I've put in are insane. Some people do 5 hours, and do you know that that person who did 5 hours and myself are allowed the same number of patients? We're allowed to have 100 patients after the first year, 30 the first year, 100 the second year. Now, do you know how many patients I can have if I become a Xanax, Vicodin pill mill? I can have thousands. That doesn't make any sense to me. So one of the things they need to do is like maybe people who have a board certification or some, like they come out of IU's Addiction Psychiatry Fellowship, like Dr. Chambers trained them, that person shouldn't have the same limit as somebody who just spent 5 hours and that's their entire training. So there's so many different discrepancies and sort of irrational aspects to all of this.
But I think the point that I really wanted to make is that, I feel somewhat responsible. We're cracking down on the pill mills. We've gone after doctors' licenses.
No, you've done amazing.
Even
you didn't have
rule,
any choice.
No, I know. The rule now has limited the prescribing habits 11% since July 1. We see the flood of people who move to heroin, and the rates of overdoses are going up. So my office has helped shrink the supply, and the supply is being filled by more powerful and more, let's say, more risky type of drugs, and we're going to see a larger crisis tomorrow. So I know what's about to happen, and this idea of what can we do today, I think, is the real point. It's not how can we get people up to speed. We've got to address this crisis today.
Yeah, but part of the problem is there's so many angles to it. Like the doctors being undertrained and the medications being underutilized by even those who treat addiction. So we have to start somewhere. I don't know that we can, instantly have everybody up and ready to do this, but we could start incentivizing people to get trained. And then when there is a crisis, like the Hep C situation in Madison County and the HIV in Scott County, we have, and I know you've moved in with teams to do HIV treatment and needle exchange, harm reduction, and offer treatment as tied to those things and that kind of thing. No, I think you're a one-armed paper hanger. You have my total admiration, but we
feel somewhat responsible.
No, you should. Dr. Frieden just said that some people are overly emphasizing that the reining in of the prescription drug problem, which had to happen. He said that's not. He said that the super cheapness of heroin is one of the main factors. The super availability. All the patients tell me they just make phone calls. It's like to your door.
Yeah.
Well, I'm sorry. Go ahead, Tim.
Yep, Senator
Well,
Larry.
thank you very much. I appreciate your presentation. It's very important in terms of the treatment aspect of it, but I guess in terms of trying to figure out how do we address this crisis, you mentioned the idea of demand versus supply, and that you rarely have seen a patient who wasn't able to get what they wanted.
That's very true.
But nonetheless, we're also hearing what you just mentioned about Dr. Friedman talking about the availability because of the cheapness of this drug. So to do a comprehensive approach to this problem, don't we have to do something to sort of drive up the price, if nothing else? Because we also know, smoking rates go down when the price of cigarettes go up.
Yeah, but how do you control the price of a drug that's an illicit, illegal drug? How would you do that?
Doesn't that call for stopping the flow, or at least making it tougher on
I just think that
people out there?
my only thought about that is that we've done that for so long. There's a book I'm getting ready to read called Dreamland that describes the entire heroin, the nuts and bolts of in it, and it's a pretty sophisticated.
It seems to me if I can make a phone call and get this,
Another thing is,
living in affluent
some of it
areas
may be reallocation of resources, but, I know we incarcerate more people than any other country by far. It's not even close. And if, I use a lot of residential programs like halfway houses, and for nonviolent offenders, if we could get more people into sober living houses and recovery houses and things like
I'm
that.
not talking about the users. I'm talking about the suppliers.
Senator, I was just talking to Director Bonaventura. We both have decades on the trial bench combined. I never had a kid or a parent that couldn't leave my court and within 5 minutes go get drugs. I never had someone that say, I quit using because I couldn't get it anymore or got too expensive.
So how much more do we throw at trying to stop the flow of drugs?
Did you ever have a case where we took your kids, we locked you up, we've taken everything we can away, and I will ask them, when you leave the courthouse, how many minutes do you think you can score?
Absolutely.
And I never had anyone say
that's
they couldn't.
been my
Then I
experience.
asked them how, I said, I took your license away, you can't drive, I can go on my bike, my mom took me. you know, your mom took you where? She took me over to Champs, there, so I can get some pills in the park. I mean, it was just.
My mom uses.
My mom uses, or I can go, but I just, the supply is just out, it's overwhelming. I think it's like putting your finger on a waterfall, I mean, in a dam that's going. I can't, and Dave and Larry, you're in this field, did you ever have anybody that couldn't get drugs?
No, but there is two aspects to this, and we're talking about the public health aspect. We need to talk about the public safety aspect. There's a recent article out of California that just came out where they've lowered all their drug penalties. Now their crime rates are going through the roof on property. And so we can't, and number one, which is going to jail. And certainly we know the Mexican cartels are doing a great job of importing heroin. We're so busy chasing Smurfs on meth, our state police units deprived, they really can't even, the cartels are operating without accountability in Indiana, and they're supplying the heroin. You know, we need resources to go get them. We can get them and catch them, and it'll have an impact. But it's twofold. You know, obviously public health's an issue, and care and treatment and all of this has been underserved, and that's your point. But we can't ignore the public safety aspect. Thefts in Indiana, I don't know why, but thefts in Indiana in the first 6 months of this year are 90% higher than the first 6 months of last year. Why? We know property crimes grow up dramatically when people, so we won't get them for meth, I mean, we won't get them for dealing, we won't get them for use, we'll send them to jail for
But
burglary.
has there been, what part of the country has had like a wonderful impact shutting down the heroin trade? I mean, even if you know, and how would you know if you tripled the budget for that?
We know the war on,
it would pay off.
we know the war on crime is never going to be won. I used to think when I was an elected prosecutor that you give me enough money and resources, I'll eliminate crime. No one's willing to write that check. And so it's going to be an ongoing struggle, always. We're not going to eliminate evil, but we can't give up on it.
No.
And you can't treat it completely with medicine.
No, but just keep in mind,
you're exactly right. It's not either or, it's both.
Yes.
There's actually a grant from the federal government looking at trying to incentivize states to pair the public health community with the law enforcement community, because the problem is we've been either or. What we need to do is say, you're going to go to jail if you don't go into treatment. Not, you're going to go to jail and then those people won't talk to the treatment side, or we're only gonna, you can't address one or the other. It's gotta be both working in concert. And the other thing that I've said nationally, and we learned from the Scott County outbreak, is public safety is what wins the minds and the hearts of the citizens. I'm the commissioner of public health. I would love to be able to stand up and say, do it because it's the right thing. And that does win some people, but you've gotta, what changed the hearts and minds of Scott County was having Sheriff McLean and Chief Spicer behind me saying, we need to do this to make this town safe. It wasn't me saying we need to do this because people are dying or people are getting HIV. It was the public safety aspect, so we've gotta work together, which is why we're here today and why we have the Attorney General's task force with those two together, and why the federal government's emphasizing it, but it's gotta be in concert, working together, not either or.
Maybe just a couple more comments.
But I would also say that underlying Dr. Adams' comments is that we still in the state have the philosophy that people that use drugs have a personality flaw, weakness. And if you look at the national variation in utilization of MAT or these treatments, Tim, I think you would agree, out on the East Coast, they think we're absolutely backwards here in terms of the way we view this. We don't look at it as a chronic brain disease that needs chronic treatment.
Exactly. The state of Ohio did a trial in 8 counties, and they're expanding it to 88 counties because it was so successful using medication-assisted treatment. And in Illinois, where they shrunk the budget, people are dying on the waiting list.
And I don't think, though, it's just, I think we did things the right way here in Indiana. We have mental health parity, so it's not a coverage issue for the services. We have put HIP in the field. That's $16 billion of new medical spending in the next 5 years in Indiana. So we've got the money out there. We've got the services. You say it's the providers. I would submit that once they start getting paid, they'll come back out of the woodwork. They're out there, and you're right. We have mental health centers that haven't been doing their job, but they will step into that.
I'd say, you know, until recently, the majority didn't do any medication-assisted treatment.
Well, I think many of them that used to be in prison and jail settings abandoned it because they couldn't get paid. So, I mean, we're addressing the payment side of it. So I think there's more capacity in the workforce than we realize. But clearly, we're a rural state,
And the further away you get from the metropolitan areas, the bigger a problem this is. But underlying all this is the attitude. And until we get the General Assembly on board, policymakers on board, even our physician community, I think if you would survey most of the providers in the state, they still have a pretty backward view of this. And I can tell you for sure, many of them say, you put somebody on methadone, you're just trading an addiction, and that's not the right thing to do. Send them to AA or NA. And as you're saying, that doesn't get it. Our methadone clinics are a debacle mainly because of the downward drift. The only ones that do stay are the worst of the worst. And they're coming in and it's a cash business and it's seedy and, you know, so in putting a lid on methadone clinics creates a problem as well, because then you can't expand access to good care. So there's good care, good MAT, good methadone maintenance treatment programs, but the only ones that really seem to persist are the bad ones, and that's the reputation that we live
And there's
with.
a lot of confusion about methadone. Is 5% of prescribed opiates for pain, and it's involved in about 30% of fatal overdoses. So it's actually a very dangerous drug. When it's and so when some people they lump methadone, like methadone, as John pointed out, methadone maintenance is a treatment for opiate addiction, and it's administered on a daily basis, and it's attempted to be controlled, and you cannot get any loosening of that daily visit thing to every other day or something until you've completed some counseling and passed certain drug tests and shown some stability. Okay, but what's really dangerous is doctors who prescribe methadone for pain, because then the patient gets a 30-day or 90-day supply. Now the patient has access to large amounts of methadone, and if they're an addict, and we talked about impaired control, and if they combine it with something like Xanax, it's a total nightmare. And then so when sometimes people want to run methadone out of the state, and they don't even know the distinction between prescribed methadone for pain and methadone maintenance for addiction. They're really different animals, and you have to sort of understand, maybe there should be even higher requirements for people to prescribe methadone for pain because it's disproportionately involved in fatal overdoses.
Is there a best, in the legal field, we have best practices, evidence-based decision-making, really looking at some metrics on what's working. Is there that in the medical field? If the information shows that medication-based or medication-managed treatment for addiction works, and the other, without it, it's 10% less, are these studies going out there? You talk about look at the Cleveland Clinic model, and you give a couple of models. Is there a best practice for addiction treatment for physicians in Indiana?
There is, but I don't know that physicians are required to do any special training other than those that become certified buprenorphine prescribers. They have to take a course that takes 5 hours or something to show they understand how the drug works and a little bit about addiction. So there's really no requirement to show that you understand addiction. You could, almost all doctors have to get a certain amount of CMEs, like you get CLEs or something, and you're not required to get them in addiction or anything like that. Here's what's one thing that's happening in the big health networks, and it's happening in my health network, Community Health Network, because we have a very sophisticated computer system called Epic. We can see what everybody's doing. So you can put almost anything on a bell-shaped curve. So one of the things you can put on bell-shaped curve is prescribing of controlled substances. And because of the computer, you can see what people are doing. So they have to record it in the computer. So what we've done is looked at the people at the far end of the bell-shaped curve who are, let's say, in the top 10% or 15% of prescribers, and to see those are the people who often cause the most problems. So those are the people that need to go into some kind of mandatory, this patient I was telling you that had 2,900 milliequivalents of morphine a day, when 100 increases her risk 9 times. That doctor didn't understand the risk at all, and he was purely thinking about pain. She always said she was a 10. He always increased it. He said he was told there was no upper limit of benefit. In other words, the higher you go, the more benefit you got. He didn't think of anything as a downside. And she was on 6 milligrams of Xanax, 300 micrograms of fentanyl every 48 hours, 240 milligrams of methadone, and 4 somas a day in one patient. Have you ever heard of that?
To get back to Attorney General's question, and don't put all this on your shoulders, but, you know, we've only hit the tip of the iceberg then right now, is what you're telling me. Now that they're pulling back
The-
requirements, we're going to see, if we're thinking it's an epidemic right now, it's gonna be cataclysmic. What you
The wave
believe,
is
what we're gonna be
coming.
seeing
The
in
wave
this.
is coming, yeah.
In the next 3 to 6 months, 3 to 12
Well,
months?
you know, in the first 2 months, the prescribing habits of doctors, this is the first time they've ever had a prescribing rule. And it was worked on by the Medical Association and the Medical Board. So once they passed that and it took effect in July, 11% decrease in prescribing. So I think it's supposed to peak out at around 50% in the first year. So the reduction of the availability is going to happen. Now, whether they're trained at the other end, I don't know, but this is the first time we even had a rule on what's the best practices for prescribing at the front end. But the wave is going to be huge. We're not, I'm afraid, getting as much Narcan out there, needle exchanges. We got to get.
You know, here's another problem, Greg, with like say buprenorphine. That could help a lot of people, especially if people follow the guidelines. Okay, do you know? Okay, so at where I work, I see a lot of people who have Medicaid and HIP. Okay, Medicaid and HIP covers it, but guess what? The providers won't take it.
Yeah. No,
And so I have all these people, and then they call for hours. Do you take my insurance? No. Do you take my insurance? No. Do you take my insurance? All day long. So the only place I can find to put these people are mental health centers. And the one mental health center I was using is now saturated, so that's not an option for the moment. And the other one requires a 6-week engagement period before they'll prescribe anything to them. And I can't write a prescription. And these are people coming from the hospital. I can't write a prescription for 6 weeks, and they can't see the doctor for that long. So it's just becoming more and more difficult. I'm just trying to treat patients, and I'm trying to. So here's my latest idea. I went to Patrick's residency, and I said, hey, you know, and they actually really liked the idea, except they're scared of buprenorphine. So I said, I want to establish a little mini addiction clinic, the medical home. They already have podiatry and they have psychiatry. I said, I want to be addiction clinic in your family practice residency. That's better than following me around to learn. It's like, it'll be right in your clinic. And you can do smoking cessation, alcohol treatment, and you can refer people that have red flags on controlled substances. They have to go over here and have an assessment. So they really liked the idea, but they were scared of the buprenorphine and how that would work. But that's actually one of my biggest needs is where do I put these people? Who will treat these people? So when they have the Medicaid and the HIP, even though you would pay the provider won't accept that insurance.
Right. So we've looked at some models like what they do in Massachusetts, which is very much a medical model, clean slate program, which we're trying to bring here to Indiana. But they have an induction center, so patients go and get their physical exam and their biopsychosocial assessments appropriate for Suboxone. They go for 6 weeks there and get their induction done. Then they go to their peripheral physicians where they've been trained and they can get their follow-up prescriptions there. Again, the model is that they're going to stay on Suboxone indefinitely. The model here is you need to be off of it in 6 months. And oh, by the way, if somebody ever prescribes you an opioid for any other reason and you're taking Suboxone, one or both are going to get denied, right? Because you shouldn't be on both.
I've seen that.
Okay, so I mean that's the reality.
So we need to improve that.
We can change some of those policies, but the reality is that we have a capacity issue because the feds have looked at increasing the Suboxone number to 250. But you go ask Andy Chambers, he says, I can't handle 100 of these folks. Why would I want 250? So, I mean, there's disagreement in the field about what's the right number. I think we all agree an unlimited number on any one panel is probably not right.
No.
Should it be north of 100? Probably. But the reality is it's the throughput, and it's the fact that it's very difficult to the Chief Justice's question, is there best practices? Yeah. There's best practices out there, but you've got to have the IOP programs, the outpatient counseling, the family supports, the AA 12-step support model, and the medication-assisted therapy, and progressive thinkers in all those areas kind of working in concert or together. Mental health centers, some do have that capacity, but it fills up very quickly. What we're talking about are these large health systems that are now going to have to step into this space that they have systematically said that's not something we're really interested in. But in an ACO, you're responsible for these folks. You got to figure it out. So the money's flowing back into trying to develop a more comprehensive approach, but it's coming slow, and it's not going to be anything that is going to handle high levels of the patients that we typically are dealing with out in the community,
You know,
particularly in the rural areas.
What about incentivizing pain management programs maybe to use more buprenorphine? Because, it really, one form of buprenorphine, the transdermal form, is FDA approved for pain, and the sublingual form is FDA approved for addiction. It's obviously the same compound. Because one of the problems is that pain management varies all over the map in quality. And the ideal pain management, like if you went to the Cleveland Clinic, you get multidisciplinary, you get those 4 circles. You get the psychological, psychiatric assessment, you get the medical assessment, you get the pain assessment, you get the addiction assessment. Then your program is determined based on, so one condition doesn't exacerbate the other condition. So I see people on sedatives and opiates who have sleep apnea and COPD. That's a nightmare.
Right.
Okay, so what about some incentivization of pain programs? Not, because the worst pain programs, this is a nightmare. Here's the worst pain programs. You make the most money when you do procedures, inject things. So the worst programs inject the patients over and over and over. They always say they're in pain because they want narcotics. So they get sort of the patient gets narcotics and the provider gets to inject them. Okay,
Well,
and that's the single worst. It's like a symbiotic, terrible relationship. And the patient always has to say he's in pain, because as soon as he says he's not in pain, or that he doesn't want the injection, then these bad providers hold that, say, then you must not need the medication anymore.
Well, again, that has to get around the federal licensing and the fact that the FDA has not approved Suboxone for the treatment of pain.
No,
So the reality is, and I'm sure ASAM is lobbying the FDA. The FDA, as we saw today, changes their mind all the time. But it may be that's where it needs to happen first, because our restriction from the Medicaid side is, there is off-label prescribing, but it's not recommended that you use things that aren't FDA approved.
There's also a tremendous number of patients who, and we said the statistic is at least a third. There's a tremendous number of patients who have both. Okay, so they would probably meet the criteria for opioid use disorder or opioid dependence, and they have chronic pain. So those people would be candidates for, in fact, they're the perfect candidates for this, because you've now prescribed something that actually works.
All you have to do is code for the addiction first.
Right.
Then they would be eligible. The
Right.
problem is that's not what doctors do.
Yeah. Now, this is an excellent conversation. I have no doubt that we are going to have many, many more following this. And so, are there any other questions before Dr. Kelly leaves today? One more.
Doctor, thank you for the education. Do you have a list of recommendations for this group? Where do you think policy changes should be made that we have some authority or influence to make?
Well, I think I touched on a number of them. One would be, to look at, funding and incentivizing the treatment side of the equation, and to find ways to train people and incentivize primary care to learn more about not only how to treat people with addiction, how to identify them, how your pain patient who is now is more complicated, that you could manage those patients, and then those are some.
Sorry, I don't mean to interrupt you, but could you send those to us in writing so we have time to kind of think about them and process them and maybe translate them into some kind of policy recommendations?
Sure.
It's a great suggestion.
Okay.
Wonderful. Well,
It's been a privilege and an honor. Thank you for so much time.
yes, absolutely. We appreciate your passion, your candor. Thank you for being with us today.
Take that issue back to the executive committee, come up with some policy ideas from this, and
Absolutely.
then submit it for ratification or recommendation to the full
Yeah,
commission at the next
be great.
meeting.
Yeah. And so if anyone watching online would like to see the presentation or didn't catch the PowerPoint, all of that information is going to be available on the Children's Commission website. For those of you who may not be familiar with that, it's www.in.gov/children. So that will be coming in the next couple of days. Please keep a lookout for that. It's already posted. Excellent. Thank you very much, Anne. Next up, we are going to have a report from the Governor's Adoption Study Committee. We're going to have Jane Bisbee with us from the Indiana Department of Child Services, as well as Sharon Pierce, President and CEO of the Villages. Jane and Sharon, please feel free to join us. Thank you for being here.
Good morning. It's still morning, right?
It
Okay.
is.
23 more minutes.
I won't take 23 minutes, I promise. Thank you for having me here today. I am Jane Bisbee, and Sharon, Come on up. You should have in your packets a document that looks like this. You probably have the color version, but it's the 2015 final report of the Governor's Adoptions Study Committee. This committee was put in place in July of last summer, so July of 14, and House Bill 1222 is in the packet, so you can peruse that at your leisure. The appointments that were made at that time were for 1 year, and the category of those appointed is outlined in the House bill. If you would look at your document on page 7, you'll see those people who were appointed by the governor. And I'd also like to thank the governor and Mrs. Pence for their interest in adoption, because adoption has always been, of course, high priority for the Department of Child Services. And when we say that we want to make us the most adoption-friendly state in the nation, it's very affirming for those of us who work with children every day. So the committee, some of the committee members are here today, and I would like to recognize them. So Sharon and I are I'm the chairperson. Sharon is a co-chair, and she's a co-chair along with Karen Sauer. Karen is an adoptive mother of how many children? 2 teenagers. And I believe she adopted them when they were teenagers. So she probably gets a hand of applause just for that alone. Zachary Kester, who is also an adoptive father and an adoption attorney, and he has adopted 2 children, so thank you. Tamara Wilson, who is the Deputy General Counsel for the Department of Child Services. She was sort of our legal mind that was on our study committee. I don't believe the other members are here. But Greg Ellis, who is a CASA, was also on our team, as well as 2 judges, Dana Kenworthy and Steve Galvin, were also, and then Michelle Jackson, who is also an adoptive mother and an adoption attorney, was on the team also. We met several times between August and May, I believe 6 times. All the minutes from every meeting are part of this report, and there is a summary if you'll turn your attention to page 31. And I'm going to have Sharon go over some of those proposals. So the summary proposals is really mimicked in the final recommendations, and we have already finished this and presented it to the governor's office. We had a lot of support from the governor's office. Lindsey Craig supported us from the governor's office, and we also had Par Stover from the Department of Child Services, and Angel Owens helped from the Department of Child Services, and Brady Brooks. So we had a good group of people who met and had a lot of passion around the subject of adoption. And frankly, in 6 meetings in 1 year, we probably just touched the surface of what those issues are. We had a lot of testimony from various parties and from various people, and including Wendy's Wonderful Kids, who came and talked to us about their program, and that program is being used in the state of Indiana, pretty widespread. So we listened to all of the input from both the committee members and from several entities that spoke to the commission, or to the study group, and Sharon will go over those very briefly, what we are recommending to the governor.
Thank you, Jane. And I want to reiterate, Danielle, your thank you to this committee. You are grappling with some of the most mind-boggling, complex issues, and they impact every child in our state. And so as someone who's been working 40 years in this field, I can remember coming into child welfare, and I think the national data was that 15 to 20% of children in the child welfare system were impacted by substance abuse. I think now nationally it's 80 to 90%. So there's an interrelationship with what we're talking about and what we heard presented so articulately this morning. So thank you all. I represented the licensed child placing agencies in Indiana. We are privileged, and it really is a privilege, to work with Department of Child Services and juvenile judges on facilitating adoption. And one of the things that Jane and I wanted to do real quickly is share with you a couple of the best practices that we looked at as we were getting to our recommendations. Certainly one of those that Director Bonaventura, you and the governor deserve great credit for is reinstating the adoption subsidy. There is child welfare data to indicate that an adoption subsidy increases the number of folks who will consider adoption, in particular in special needs adoption. It stabilizes special needs adoption, and it prevents disruptions of adoption. So certainly it's beyond good. It's great for kids. And so we thank all of you for your leadership in reinstating that subsidy. Another best practice was promoting post-adoption services available to all adoptive families. Again, Indiana does that, and you know, one of the things that we emphasize through that post-adoption services program is that adoption isn't an end to a process. It's the beginning, really, of a lifelong commitment. There are 3 organizations in Indiana, Children's Bureau, SAFI, and the Villages, who are all engaged in partnering with Department of Child Services post-adoption services available to any family who's adopted, whether it's private, domestic, or special needs adoption in Indiana. Another best practice that we can be proud of that's instituted in our state. And finally, as Jane mentioned, we hosted 2 leaders from Dave Thomas Foundation for Adoption. They've certainly been well noted. I don't know if any of you know, Dave Thomas' first restaurant was the Hobby House in Fort Wayne. My family and I used to eat there after church every Sunday, but their Wendy's Wonderful Kids best practice focuses on providing grants to organizations and funding social workers to work exclusively on finding families for the most difficult to place children. So, you know, that intentional focus, instead of juggling all the balls that all of us do, all of you do in our work, focusing exclusively on that. And their national data shows that a child, depending on their age, is 2 to 3 times more likely to be adopted if they're involved with a Wendy's Wonderful Kids recruiter than they would be without. And again, there are 3 organizations in Indiana, Children's Bureau, SAFI, and the Villages, which are all partners with the Dave Thomas Foundation for Adoption. As Jane mentioned, our committee's role was short and sweet. We were kind of a SWAT team, I think, in terms of looking at Indiana because of the governor and First Lady's commitment. And we're hoping to make recommendations that will be integrated into the work that you're doing. On page 32 of the report that you all have, we'll just real quickly go through those. Our first recommendation was an adoption brochure that would help articulate and promote post-adoption services. And again, leave it to Department of Child Services. We already have one of those. In fact, I'll pass it around here. But continuing to do more to make sure all of our adoptive families in Indiana know that post-adoption services are available to them. Working on a social media campaign and other adoption awareness efforts, and we were able to hear from a variety of communities. Our juvenile judges, Judge Galvin and Judge Kenworthy in particular, were very articulate in the effects of adoption fairs and involvement with their courts that they felt were improved. And so one of the things this emphasizes is that in any area we have to move to where communication is moving, and clearly social media is that. So Jane, want to?
Yeah, I was just going to point out that several juvenile judges, including both the judges on our committee, have participated in National Adoption Day and schedule many adoptions on that day in their courts. So that's been a tradition in the state of Indiana for many years.
And then certainly the governor and First Lady have established November as Adoption Awareness Month. May is Foster Care Awareness Month. And with the percentage of opportunity for children in foster care to be adopted by their foster parent as that forever family, that's really powerful too. So, you know, continuing to grow our commitment to the focus on those. One issue that might seem small but could be preventative of adoptive families moving forward is the fact that if that family is already a foster family, they have had to pay for fingerprints and some of the background process, and often it is required that that be duplicated to become an adoptive parent. So that seems to be something fairly simple that we could fix. And then creating a more permanent body, you know, similar to all of you, to continue to study and advocate for adoption. And certainly our recommendation and our reason for being here today is that we hope you'll integrate looking at adoption, really finding that forever family for children who have been impacted by drugs, alcohol, incarceration, whatever the issue may be, serious illness or death of a parent. We know children grow and flourish best in a family, and that's really what our focus was all about. So The continued commitment to integrate post-adoption services, Director Bonaventura, I think your team have done a phenomenal job. It's a great example of that public-private partnership that we know is one of the more successful ways to problem solve these difficult issues. And I always have to put the face on these issues, so I just wanted to show you a little gal. This is Sammy. Sammy was born at one of our children's hospital. The nurses called DCS and said, "You're never going to find a foster family to take care of this child." And I'm thinking, they don't know Indiana's foster families, do they? Or those at the villages. We were privileged to have a family that stepped up. Sammy was unable to hear, unable to speak, was supposedly unable to ever walk because her mother was involved with incessant drug abuse the entire pregnancy. Okay, this is Sammy at age 2. She's got that little walker. She's had a cochlear implant. She's able to, hear. She's got very thick glasses, but she's able to distinguish. She knows which one of us at the villages keeps dum-dum lollipops on our desk and, heads right to, so she can see what she wants to see. This is Sammy a week ago. She is 6.5, but she's heading to kindergarten a year and a half late. And her foster parents are both 65 years old. They've committed to their sons that if something happens to them, their sons will have Sammy's back. They have fully adopted her. So I think to us, that's what it's all about, a forever family for Sammy and all those other children who need it. Thank you.
Questions?
Go ahead,
Dr. Adams.
I see that you have one of your suggestions is a permanent body to study and advocate for adoption and look at barriers. I have a lot of friends and family who've adopted and we've even considered it. And there is such a wide variety in experiences. And I have a family who spent over $60,000 in 2 attempts to adopt that both failed. And I don't know if you ought to end up looking at the agencies and out-of-state agencies in particular. There's one in Florida that I'm sure you're familiar with. And then you have people, I have a family member in Fort Wayne who they've got 4 kids and they call them and ask them to take another one. And so have you looked at pricing and parity for people who want to adopt? Because I think a lot more people would want to if they weren't scared off by the story of the difficulties that some people have faced. And quite frankly, what I think are people preying on some of these potential parents out there.
Well, certainly it's one of the subjects that we touched on at a high level, but we did not delve all the way down into those individual situations. And that is one of the reasons why we're making a recommendation that the commission and like a body be in existence to sort of delve way down into some of those issues that involve a lot of different agencies, involve statute, involve centralized resource center, involve financial resources, so it's really an encompassing issue. And so that is one of the reasons why we knew that our 6 short meetings in the 1 year that this House bill allowed us to convene, that we were not going to solve those problems. So that was the impetus for that particular recommendation.
And I think a theme throughout all of our meetings was really wanting any potential adoptive parent to have a consistent experience in Indiana. So that would be something that we would all be continuing to work towards and certainly want to serve as resources to all of you to assure that. Because again, we know children grow and flourish best in a family. That's where they all belong.
Excellent. Any more questions today? No. Thank you so much for all that you have done here, the recommendations, the time and effort that you've put in. We greatly appreciate that. I can tell you that these are all actively under consideration, not only by this commission, but by the governor. We have had conversations with this. We have reviewed the report. Those conversations are going to be ongoing. For the purposes of this committee, I know that there's a recommendation to look at making a task force and including it under the Children's Commission. We certainly want to take that under advisement. The Casey Family Foundation is also going to be helping us decide where to best place different topics, issue areas, and the makeup of the actual commission. And so that will be part of the conversation, and we hope to revisit all of this very soon. So thank you so much. Appreciate it.
Thank you, Danielle. And on behalf of the committee, those here as well as those aren't here, it was our pleasure.
Thank you. At this point, At this point, we're going to go ahead and take a quick 10-minute recess, and then when we come back, we will be hearing about the underreporting of crimes of domestic battery or domestic or serial battery. Thank you. Yes, lunch is out there. It's 11:50. Thank you, everyone. Next up on the agenda, we have the underreporting of crimes of domestic or sexual battery. We have two presenters today. We have Indiana State Representative Christina Hale, as well as Dr. John Parrish Sproul, who's director of the IUPUI Global Public Health Communications. And so I'd like to welcome you both today. We look forward to your presentation.
Thank you very much, and I want to thank the committee as well for taking on this issue and listening to us every time we've come to present. It couldn't be a more important issue in my mind, and I'll just give a little bit of context to the study before I turn over the presentation of the report to Dr. Parrish Sproul. As most of us in this room are aware, the Centers for Disease Control conducts a study that comes out every other year, and it was came to our attention from their 2008 study that Indiana happened to be the second worst in the nation when it came to the sexual assault of our young children. In fact, nearly 1 in 6 Hoosier girls are sexually assaulted by the time they're in high school, and an untold number of boys because that data had not been tracked. So clearly, this is an extremely alarming fact, and caused a lot of people to want to drill down on those numbers. Now, what does that mean, raped or sexually assaulted? Well, that is, according to the Centers for Disease Control, their definition of assault, not necessarily Indiana's. And as we all know as well, the definition of rape in Indiana just changed as of July 1 of 2014. So before that time, for example, in Indiana, rape could only occur between a male and female. And today there is same-gender rape that's included in our law. That said, that's a big, mysterious number as well. You know, this covers, you know, the CDC's definition is so broad, it covers a lot of different crimes. So everything from child seduction to date rape, random acts of violence, to incest. So this is a big, complex problem with not a lot of insight. So it didn't seem to make much sense to respond in terms of policy or adjusting law or creating new laws, because it's clear we could be creating a new statewide campaign, for example, No Means No campaign to combat date rape, when we find out, no, in fact, our issue really has to do with incest, for example, or some other crimes. We also had no idea really of how this would map out when laid over, you know, the state of Indiana. Where are our problems? Are they specific to urban areas versus rural? You know, we just knew that there was so much that we didn't know. We were paralyzed and didn't really know how to begin to attack this issue. At the same time, it's clear now that the Indiana Coalition Against Sexual Assault was experiencing some issues within that organization. That was our one statewide entity that was really the advocacy group that was kind of driving good policy in this regard. So we discovered we have this terrible problem, and also we were lacking the infrastructure and the knowledge really to do much about it. So first step was really to pursue more evidence, more information, so that we could discover what are our issues here. So in working with Dr. Parrish Sproul, who is the founder of the IUPUI Global Public Health Communications Department, kind of discovered what would a study look like, what are some first steps. I also have to admit I made a rookie error. So the first time I was proposing this kind of study, I thought, oh, well, we'll send it to Summer Study Committee. And I thought that meant that they'd really study it. I was thinking social science and academic study, and Representative Frizzell's probably laughing at me over there, but it turns out, you know, no, sometimes that only means that you talk about an issue for about 45 minutes, and so I got the call like, hey, you're up, you know, it's time to talk about sexual assault and as it relates to children, and I realized, oh, well, that was my opportunity to make this committee aware of what the issues are. So I brought in some people from the field, advocates, survivors, all kinds of people that work on these issues, therapists, to give a sense of what the problem was, what it might be, and where why it was so important that we really take a look at once again, that really scary, startling number, 1 in 6 girls in Indiana having been assaulted by the time they're in high school. So average age of assault clearly was quite young. What that assault was, where it happened, by whom, what the circumstances, context were, still very mysterious. So there were a number of things that our original study called for, and it was originally to be directed by the Department of Health, but this also passed in a non-budget year, so I want to give credit to the to the ICGI. They stepped in and gave us a partial grant to perform this part 1 of the study. So this doesn't exactly cover everything that the legislation called for, but it does give us some insight into what else we might want to know and what direction we might want to take in future. So we were very intentional as well in the General Assembly to ensure that this report come back to this body in particular, so that you could direct what next steps might be, particularly with in the vacuum of a statewide organization like INCASA that could wrap their arms around it. So with that, I guess I will ask Dr. Parris-Sproul to come up, and perhaps we'll just wrap up at the end with questions, and if you're ready. I'd also just like to let everyone know that Dr. Parris-Sproul is hearing impaired, so if you would just please be mindful of that when if you have a question that you need to ask of him. So thank you.
Could you give, we have some new members, just a little summary of the legislative charge to this commission that your talk is geared to. We were charged with studying this issue, and part of, and I think maybe that came out of the study commission legislation, tasking us with looking at this issue.
Actually, the legislation read that the Department of Health was to conduct the study, and the study was to go to the Legislative Council, which it will when they next meet, and also to this commission. So really, it didn't go beyond that.
It's just a report. Your job is to report on the legislation.
This is a report, and I do have some suggestions regarding next steps, if that's ever appropriate to suggest.
All right.
All right, thank you.
Probably will be today.
Good afternoon. In the last few years in my work, I've had the opportunity to work on avian flu, reducing morbidity and mortality in Central Java, to deal with dengue fever in Sri Lanka, polio eradication in China, and indeed the Ebola outbreak in Sierra Leone. After immersing myself in the data with adolescent sexual assault, I'm convinced all of those problems are actually more amenable to solution than this. This is a very difficult thing to deal with, and yet it's just as tragic and it can cause just as many problems. And so I don't envy all the people that need to do something about this, but we clearly need to do something about this. Just to refresh everyone's memory, Indiana has the second highest rate of forced sexual intercourse among high school females in the nation. Approximately 1 in 5 will be sexually assaulted in the state by the age of 18. This all from the best available data we have from CDC and other sources. And so while we have a lot of good people and programs in this place, we're not making progress. And I think about that, and I think about why is that the case, and in some respects I always have to relate those kinds of things to personal issues, and I think about my own disability, that of being hearing impaired. I didn't lose my hearing until I was about 40, and so I never really knew what it felt like to have a disability. What's even more important is it's what's known as an invisible disability. When you first meet me, unless you make some special effort to see my hearing apparatus, you don't know that I'm disabled, and so you will treat me as if I'm not. And that can have consequences for how we interact with each other that sometimes are comical, sometimes are tremendously problematic. Well, the consequences of sexual assault are invisible also. Think about this. With numbers that high, 1 in 5, there's not a high school in this state that doesn't have a sexual assault survivor in it. There's not a community in this state that does not have a sexual assault perpetrator in it. We don't always know who they are. We don't always suspect who they might be. There's nothing special looking about them that might let us know. And yet, here we have this problem, and we know it has dire consequences we talk about. Indiana does not aggregate the data necessary for tracking adolescent sexual assault, making it difficult to formulate policy and programs effectively. When I first started looking into this problem, I was surprised to find that we don't have that, and in fact, previous studies have called for creating some process and some repository for aggregating this data, and this study will indeed echoes that particular call. Imagine trying to manage the state budget without having any data related to your revenues and your outlays, and you just sort of magically expect it to somehow balance. You know, we can't, or in the city of Indianapolis, where we collect crime data so we can target particular neighborhoods to try to reduce issues because we know based on that data what it is we're trying to do. And yet we don't really have good data that helps us allocate resources and create solutions and policy approaches accordingly. Underreporting contributes to this problem because when it's not reported, then we don't have any data to aggregate, and and this leads to several problems. First, it leads to understating the problem. If crimes aren't reported, then we don't know they exist in the main sense, and so it's difficult for us to do anything about them. And it also makes it seem like it's a smaller problem than it is, and that can lead to reduced impetus to do something to ameliorate that particular problem. Second, and I think this is really important, it leads to de facto protection and even tacit support for the perpetrators. The odds are, if it's not reported, not caught, no harm, no foul, right? And when we see in the news a recent elite prep school in a New England state where this has been going on, and now somebody's brought a suit, and what we find, at least from the preliminary evidence that's been leaked out, is that this isn't just a one-time affair, that this is routine in this particular environment. Tacit support for the perpetrators. And often when we talk about victims protecting themselves, we forget that we really need to focus on getting people to understand why it's not a good idea to be a perpetrator as well. And I think that that's really key. It also, importantly, leads to a disconnect between victims and services. You don't report it, then nobody can help you. And if you can't get help, you will suffer the long-term consequences of having been a victim of sexual assault. And even if you're a survivor, that doesn't mean you're a survivor who thrives. It just simply means you survived. And there's an important qualitative difference there. So this study is focused on the issue of underreporting. I want to make a parenthetical comment that while we were mostly talking about females, one of the things that became clear to me in this study is we do in fact have a small percentage of males who are the victims of sexual assault, at least in terms of the data that's indicated. But I really think that deserves its own separate study. I think there's a qualitative difference to the stigma about reporting and about acknowledging that particular problem, and it may well be that that problem is much larger than we think it is, and I really think there needs to be a study focused on that alone, because otherwise, even as we collected data, it was a lot easier to identify the problem dealing with females, even though we still have, as I will point out, a large underreporting problem. And so I do call for that particular study. Background. So the process, is that first of all, it's well known that feelings of shame, guilt, and fear might lead someone to not report being a victim of sexual assault. There are plenty of studies and plenty of reports about that. If a person somehow finds the courage to report, even while experiencing such devastating feelings, it is therefore important that the process be one that is both encouraging and affirming. So you've been the victim of sexual assault. You feel shamed, you feel guilt, you're maybe worried about the consequences if it happens in the family, and so you don't want to talk about it. That's, in some respects, we can all understand why that person might feel very closed off and very discouraged. But suppose they do want to tell someone. Suppose they want to tell somebody and do something about it. If that's more painful than the sexual assault itself, it's still not going to happen. That's something, ultimately, we can do something about. We can't necessarily take away fear or shame or guilt, but what we can do is make the process one that can help us deal with that in ways that are much more effective than we often do. Should the reporting process prove too difficult, unnecessarily unpleasant, or even re-traumatizing, the victim is less likely to report, leaving him or her to silently suffer with the after effects of the assault. This, in effect, helps both protect the perpetrator and leaves the victim disconnected from assistance. This may or may not influence a perpetrator's choice to assault in any given instance, but a dysfunctional reporting process certainly does not contribute to any sense of deterrence. While silence may be the best protection for the perpetrators, it can often have serious long-term negative consequences for victims. That's I took from embedded in the actual report. And I think the key thing there is that ultimately the best solution to any health problem is prevention. And what you want is your deterrent system to help create prevention of the problem, because you don't really want to prosecute people and you don't really want to have to deal with that. You want them to not do it in the first place. And so we have to have a system that would make that seem reasonable. So what we did in this particular case, because as I pointed out at one of the earlier times I talked, we're dealing with the identity of indiscernibles here, is we collected the ACE survey, which has a long background. We collected a survey of teachers and dealing with these their observations. We did focus groups for people who work with adolescents, including teachers, forensics nurses, and staff from after-school programs. Individual interviews with service providers and physicians. And we also did some GIS mapping of Criminal Justice Institute data dealing with reimbursement of sexual assault services, is giving us yet another picture of where this problem is located throughout the state. What we were trying to do, in a sense, is to get at what we're not able to get at through law enforcement data, for example, because law enforcement data, by definition, only deals with that which is reported. And we also, even the ICJI data is only dealing with that which we find out about. And what we're trying to do is find out about something that we can't find out about. And I think that we did this in some indirect ways in trying to solve that problem. Results. Our ACE survey we collected data from all 92 counties. These were all from adults over the age of 18, reporting on what happened to them prior to the age of 18. And it's all completely anonymous. This survey's was originated by Kaiser Permanente and the CDC. There have been large, ACE stands for Adverse Childhood Experiences, I'm sorry. And the point of, and so the instrument's been used and validated, and I thought that was a good place to start, because it allows people to reflect back on what happened to them, and so there's a temporal sequencing there that gets at data that wasn't reported. So you can see that 25.6% of the respondents in the survey reported that prior to age 18, someone had touched or fondled their body in a sexual manner, with 85% of them saying it was against their wishes. And only 18.4% of those who indicated that they had been sexually assaulted reported this to a doctor, nurse, or healthcare professional, much less to law enforcement. What that would suggest is, however many sexual assaults we get reported in this state, there could be as many as 4 times more that are not reported. That's a huge potential problem. And I would also add parenthetically that if absolutely overrun with people trying to deal with them. And so we need to think about this long term. If we're successful actually in getting more people connected, we have to be able to successfully help them in some way or deal with the consequences if we're going to actually make inroads to the problem. Underreporting is high and a significant part of the problem. It keeps that cloak of invisibility, and it keeps us from doing all of the things necessary to try to reduce that issue. I would also add that with the ACE survey is that it's designed to look at the long-term consequences of adverse childhood experiences. And what we know is that people who are sexually assaulted have higher incidence of substance abuse, higher relational problems, professional problems, and other kinds of issues that impact their life all along. It has economic as well as social and human consequences for the entire state of Indiana. 29.5% report a person who lived in their home was involved. 20.9% was a relative. Could be a brother, cousin, father, whatever. 51.4% assaults were from a family friend or a person whom they knew and didn't live in the household. 75% of assaults were from somebody they trusted. Could be a family member, aunt, uncle, could be a scoutmaster, could be a teacher, etc. Thus, if we think about solutions, what we have to say is it's not that we shouldn't focus on families, but that exclusively family-based solutions would prove inadequate to address the issue, because if we wanted to address the issue solely in the family, we would be putting the perpetrators in charge of solving the problem. That obviously isn't going to get us where we need to go. 62.5% involve verbal persuasion or pressure to get them to participate in sexual experiences. 10.5% involved in threats to harm them if they didn't participate. 34.2% were being physically forced or overpowered to make them participate. And 28.9% were being given alcohol or drugs. This is not how we conduct healthy relationships at any age. What this means is that people aren't learning really how to relate to each other in a healthy manner, and that sexuality is encased in that whole notion of what constitutes a healthy relationship. If I have a healthy relationship, then I'm not using verbal persuasion or pressure to get you to do something that we both know isn't a good idea. That is not how a healthy relationship functions. And if they're using threats of harm if they don't participate, that definitely is beyond the pale for a healthy relationship. Physical force or overpowerment, I think that goes without saying. And of course, giving an adolescent or a younger child alcohol or drugs in order to get them to engage in this kind of activity, that clearly is inappropriate and unhealthy. I might also add that our data showed that the median age for first sexual assault was between 9 and 10 years old. Okay, and so this is not what we're talking about in terms of how we should be relating to each other. If not the family, then where? I turn to the schools, as if teachers didn't have enough to do. Okay, schools are a logical and likely locus for reporting. Teachers generally understand their duty, it's their duty to report, and for many reasons they are often reluctant to get involved. So the teachers that we talked to and the teachers that we surveyed almost universally say, yes, we know we're supposed to report, yes, we've had some training, and for sure we would prefer not to be involved in these particular kinds of circumstances. Teachers are reluctant to talk about the topic in generally, especially the male teachers, which was an interesting part of the process, which is part of the clue for me that we need to be looking at males as almost as a separate category. The process of reporting is often not clear to students or to teachers. This varies from school system to school system. Sometimes they don't know if they're supposed to report to the principal, if they're supposed to report to the Department of Child and Family Services, if they're supposed to report to the social worker, or exactly what it is they're supposed to do. In some schools this seems to be clear, but in other schools it's not clear at all, and people can't answer for that. Both students and teachers may be reluctant to report for fear of the repercussions for doing so. And so for students in focus groups, for example, it may be that they are afraid of being homeless because it could disrupt the family. It may be that they're going to lose their boyfriend or girlfriend, etc. Or it may be that it's another teacher and they're afraid of the results of something like that. For teachers, as we all know, reporting crimes means that sometimes you get ensnared in a process that keeps on making life difficult for you. And when it's happening right there where you work, there's a lot of effort to sometimes avoid the issue if at all possible. Some teachers see the system as reactive but think it should be proactive, which is to say the teachers say, yes, we should be dealing with this problem, but we only wait until after there's a crime. We're not teaching people about healthy relationships and how sexuality fits into those healthy relationships so that maybe some of those crimes don't occur in the first place. And as a consequence, we don't use education, which is an obvious tool for amelioration, in a positive way to try to solve this. Support resources are often either insufficient or non-existent to facilitate the best handling of the situation. Some schools have social workers attached to them, some do not. Some don't have any particular process at all, which makes it difficult. Teachers are often told or instructed to not talk about the topic of assault or abuse, especially in class. Male teachers are often afraid to have such conversations with female students. Students are often willing to have the hard conversations, given the space to do so, but often they're not given the opportunity to even have discussions about these kinds of relational issues. And this may well be because of pressures of the classroom schedule. I'm not going to suggest that it's not problematic or that I even understand all that. All I'm saying is it's not there, and there's a consequence to that. Teachers observe abuse from within adolescent couples due to the general way in which students learn to relate to each other. And once again, that speaks to students not learning at home or in school how to engage in healthy relationships with each other that doesn't include sexual assault. One of the things that was interesting is one of the teachers noted in a focus group, except for sex ed programs in public schools, we tell them, don't have sex until you're married and just abstain. So they're not even getting those messages they're not even getting the message you're a sexual being, but they're being told in our sex ed programs, actually they're abstinence programs. And obviously they're not abstaining. 11% of our high school population has had a baby this year or they're pregnant. So they're not abstaining. So what kind of message are we communicating in our education about healthy relationships, about healthy bodies? But we still have this significant issue. So are we giving young people the information and the tools that they need to be able to keep themselves safe from that? There's a high level of ignorance, not only about the issue of sexual assault itself, but this is the issue of how should we go about relating to each other? How should we engage with each other? And the teachers observe this because they live with the adolescents every day. They can see it better than the rest of us because it's a problem that's right in front of them, which is one of the reasons we were interested in talking with them. And I think this quote captured what a lot of them were saying. The adding to this problem is social media adds complexity to an already difficult problem. Policy and procedures have not kept up with technology, but adolescents have done so. Let's put it this way. I'm going to go out on a limb here and say most of you are just like me and you didn't grow up with social media. In fact, you didn't experience social media until you were well into adulthood. It's only been around for about 10 years. And so, our relationship to social media and our adolescents' relationship to social media are completely different worlds. And but their ability to learn how to use it and how to engage the media doesn't necessarily match their maturation and their knowledge with how to engage in healthy relationships, which leads to some tragic kinds of consequences. Again, I chose some quotations from teachers because I think they captured the essence of some of these difficulties well. One teacher said, and I think, undoubtedly, as I think about how our kids communicate, social media definitely plays a big role in probably scaring kids from reporting it, because once it gets out, and once there's a conversation, somebody's going to try to belittle that person, and then once that happens, once the first shred of any conversation, whether it's be right or wrong, it's going to get blown out of proportion, and stories are going to get added, things are going to get deleted, truths are going to be hidden, and lies are going to be added. They're talking about adolescence, not our political process. And so, it used to be, that you think about worrying about maybe just your community or maybe your block knowing about what happened to you. Now it's, that the state, people, and that the country knows what you were doing. And by the way, the social media goes on. And so, there's a whole traumatization that goes with a person who honestly are thousands of miles away from you and have no clue about who or what you really are. Once it's on the internet, the whole world can access it. And so you have somebody that's already had a big enough trauma in their life, and now they have to go through the day wondering what everybody's thinking of them because they've seen this issue, etc. And so sometimes what happens is that students will threaten other students. They'll post it on the media unless you submit, and that becomes its own kind of crudgeon in order to get students to engage in behavior that basically would count as pressure or forcible rape. The second one, that's a little bit smaller, but I think this is really key, is that there was an example in a community, is this the right quote? Yeah. The example of a community where a 13-year-old boyfriend asked her to text a naked picture of herself, or a picture of her naked self, I guess I should say that correctly. And she does, because she's 13 years old and she thinks she loves the kid. And then it gets posted on the internet so that 15 or 20 of his friends can look at it, but then they share it with a whole bunch of people. And so she wants to do something about it, but the local prosecutor says, well, we're going to prosecute you for child pornography because you posted the picture. And so who wants to report when they're likely to get prosecuted along with the people who posted the picture all over the place? Now, I don't want to castigate the prosecutor. I don't want to have to make that decision, and I'm not a lawyer. But what I can say is we don't have policy that helps victims in this particular case and helps us do what we need to do. And I really think that we need to consider that particular issue and to try to make our policy and procedure and law come into line with the technological possibilities here. One of the things that when we wanted to map data is that we realized we simply don't have the kind of data that we needed, but we did have one set of data that we got from the ICJI that's about the reimbursement for hospitals. And I think this is instructive in part because it looks at incidents per county. The counties that are in white is because no data was reported, and the darker the red, the bigger the problem. Now that was in 2013. Now, if we look at incidents per capita, because obviously there's more people in Lake County and Marion County and Allen County and so forth, what we find is that some of those bright red states are also rural states. They're not necessarily simply an urban problem. And if we go further and we look at per capita under 19, our adolescent sexual assault, again, the white counties are where we really have no data. What we find is this isn't just an Indianapolis problem or a Lake County problem or an Allen County problem. This is an all over the state problem. And it happens in rural areas and it happens in urban areas. And this data is simply the tip of the iceberg of what happens.
I just wanted to underscore too, as we look at this, I think these slides are a little bit misleading. It says sometimes with the white counties, 0 incidents per person, I think 0, and it's similar on some of the other slides. And the white counties are inconsistent from slide to slide. That means that nothing was reported, not that there were 0 incidents.
Right.
So it's just a dearth of information. It does, but this sort of seems to indicate that there are 0 incidents.
So while the legend was put there by my mapper, the point of it is the white counties, we just simply don't have data that, to represent in this slide. And I think what's important with these is to indicate that this is an overall Hoosier problem. It's not simply a one location problem. And I also would say with this is that we have counties where we don't have reporting. We have all the counties have underreporting, and this speaks to the inadequacy of the data that we have in order to help us address the problem. Consequently, at least preliminary, I make some recommendations that I think can be helpful. One is to create a process and repository for all data related to adolescent sexual assault in the state. This effort should be proactive, ongoing, and integrative. It should include law enforcement, ICJI, and other relevant data sources to provide a comprehensive picture of adolescent sexual assault across the state. We get a clearer picture of what's happening, where it's happening, how and why. It gives us a much better idea to think about how to address the issue. Teachers should be given better training regarding both the short and long-term consequences of sexual abuse and assault, and how to recognize the signs and how to learn how to have reporting conversations that encourage adolescents to disclose, and how to get them connected to necessary support services. The teachers that we interview and we talk to, they want to do right by students. Make no mistake about it, they really care. That doesn't mean in all cases that they necessarily know what to do or how to do it, or that they're very best in this particular situation. Those are difficult conversations to have, and they deserve better training that makes them better at it if we expect them to do a better job at something that's beyond their subject matter, but necessarily not beyond their purview. Students need a multi-year curriculum that focuses on how to develop and maintain healthy relationships and addresses the full range of issues that young people face as they enter such relationships, including choices about sexual activity, managing conflict, and dating violence. The truth of the matter is that they get almost no instruction. As we saw earlier, leaving that to the family is a bankrupt solution, because oftentimes the problem's worse at home than it is when they go anywhere else. In fact, in the survey data with teachers, you find that most of the teachers think that their students are not safe in their homes, their schools, and their communities. These are close observers of our kids, and I think we should take their words seriously. Indiana needs to develop a coherent and comprehensive policy that assists victims of sexual assault when social media are involved. This is going to require a lot of study and some legal thought about how to do that, and I think there needs to be more research done with that. The state should explore a policy that includes restorative justice models as an option in adolescent sexual assault cases. This could encourage reporting and successful mitigation of consequences in many cases. And I think the point of that is that we need to consider a full range of options for how we deal with this. that sometimes they don't report simply because they think they're going to be taken out of the home, or that they're going to be homeless, or the problem's so bad. Sometimes it causes them to run away, and then they become human trafficking problems. And so what we need are an array of possibilities for how this can be dealt with that are more friendly to the people who are victims, so that they can become thriving survivors rather than people who simply escaped and still alive. School and after-school programs need trained adults to facilitate discussions with adolescents related to sexuality and relationships. Students need to learn how to have informed, frank, and thoughtful discussions about the topic. We cannot expect people who are ignorant to necessarily make the best decisions, particularly when they're 12, 13, 14, 15 years old. And so we really need to create some kind of space to do that, and we need to have that guided by people who know what they're doing. There are a number of programs around the world and around the country that could be useful to look at, but that requires another study to look at best practices and evidence base for that. But I think that these recommendations don't solve a problem, but they can make inroads. I think there needs to be more research done, but I also think there needs to be action. Thank you for listening. Are there any questions?
Thank you. Any questions from the committee members? Yes, Representative Frizzell.
Thank you, Doctor, for your presentation. I have one question. The crimes, as I view them, have they been sexually abused themselves in their lives? What percentage? Is it all of them or part of them?
We did not look at that within this study. I think what this study also brings up are a lot of questions. What do we need to know that we don't know? And I think you make a very strong point, Representative Frizzell. A missing piece in terms of the social science, in my mind, also has to do with looking at the incarcerated. And I've been doing some work, for example, in the women's prison, because they actually invited me. They took notice of some of my work on sexual assault, domestic violence, and that kind of thing, invited me, and wanted to tell me their stories, but also wanted to be part of the solution. And they have over on the west side in Speedway at the women's prison, they have a public policy class. And virtually every woman in that class raised their hand to say, I was assaulted. And their message was not that we're victims, we need more help. It was, we want to look out for the sisters and daughters that we left behind, because it's happening in our communities, in our homes, and we want to be part of the solution. So that's very anecdotal. It's not based on social science, but I felt like it was a good indicator. And, in terms of Dr. Pearsprall's point regarding men, that's also a big blank in terms of our knowledge base, and it deserves, to make good policy, we need better information, and there's just so much information we don't have.
Yeah, I just feel that's probably a big component and something we need to find out, so thank you.
Right.
Christina, you very diplomatically raised the problem about, at the same time we're kind of recognizing the issues with sexual assault underreporting. We also have our, let's say, the crash and burn of INCASA. We went to court and asked that the court appoint a receiver, so Deborah Daniels is now the receiver for what is left of INCASA. We're hopefully within the next month or so we'll be standing up a INCASA 2 or whatever it's called with a new board and kind of a new mission. But at some point we're going to have to look at whether to continue to have two different organizations, one for domestic violence, one for sexual assault, or as some states seem to have merged them into a common sexual violence and try to, they are different problems and the victims are quite different, but is there any way that you all could incorporate some review to kind of help us with this? Do we continue to go down the path of having two separate organizations? Again, the separate administrative functions that seem to have broken down. It wasn't the mission of INCASA. Or whether we go the role of the states that have, let's say, the dual purpose mission of is that something you all could help with?
Yeah, I'm sure that we could help with that. I think that actually Deborah Daniels is very close to a suggested solution. So my understanding is that there will be some kind of solution suggested in the coming weeks. That said, just through this study, I can tell you a point that Dr. Parrish-Sproul made had to do with new and emerging technology and social media platforms, which the study called for, but it's just such a big thing. And quite frankly, we only had a grant for $65,000, so I think we did the work that we could afford to do. But I gotta tell you people, when I was a kid in high school, I was on the phone. My dad picked up the other line, like, Christy, get off the phone. And they knew who I was talking to because they'd have to call my house and ask to speak to me. Completely different world today. And I think you, General, know better than anybody in this room because you have taken such a leadership role fighting human trafficking, for example. Well, we often think of human trafficking as being women in particular from Eastern Europe or Asia. Well, as you know, it's the girl next door who's been groomed through social media and, you know, hey, come to Cleveland. She never makes it back home from Cleveland, not the girl that she left. There are so many things that we have not yet anticipated that are changing these crimes. And, you know, you made the point too, Dr. Parrish-Sproul, child-on-child crime, blackmail. There's so many iterations and nuances of things that we haven't even begun to anticipate. And I imagine there are a lot of things that are happening today that we don't even know about. You know, I'm barely even on Instagram, let alone Snapchat and all these other things. And, you know, you read, I believe that there's a new app out there in the past couple of months. It's a place where young under 13s hang out, and people posing as under 13s or accessing live video streaming from slumber parties and just really crazy things that we've not yet anticipated. So it's such a big topic, and I think that this study really begins to unpack how much stuff there is there that, in my mind, it would be difficult to commingle that with one agency. My ultimate suggestion here was going to be there's so much that we don't know, but we know that this is an urgent, awful problem that Indiana has. We're second worst in the nation, which is, I know, unacceptable to everyone in this room, that we need to take this issue and have someone own it. Someone really take responsibility for it, to think through all of these different angles, you know, where our law is inadequate, where just our breadth of knowledge is inadequate. You talked also about the issues of, you know, now we have some children trying to report and some teachers trying to be responsible and do their duty and follow through, but we have a case, and I'm doing a deep dive on this with a lot of people in the field. So a teacher during a training, you know, gave up to give her own testimony to say, you know, it's just in this moment now I'm discovering a little girl 2 years ago tried to report to me, and she came in, you know, so upset, just beside herself, crying. Last night, Daddy ate my cookie. Last night, Daddy ate my cookie. And I couldn't figure out why she was so upset. But she was using her vernacular. You know, she was trying to report, and she said, honey, we can get you another cookie, not a big deal, let's calm down. And then, you know, just in that moment when she was going through the training years later, she's connecting the dots thinking, my goodness, you know. But we have so many good people out there that just don't even have the tools right now to follow through when they need to, or to listen in the right way, let alone our kids that probably wouldn't know how to report if they needed to. So that's much too long an answer for your question. So I guess I want to say, yes, we can help, but I just caution us all that it's such a big topic that I hope that it lands in its own dedicated home.
You talked yesterday, and so you think you're kind of waiting to see if there was an agency that was looking out for these issues, advocating, asking for legislation, looking for funding. Now there's no agency, but there may be an announcement of something soon.
I believe there will be, yes. Since INCASA was put into receivership, from what I understand, you know, that process is almost over, and that there will be, again, you know, some kind of not-for-profit entity that can be the leading voice on this issue statewide as a referring agency, as an agency of advocacy, and then also to be able to channel what federal dollars and other things that need to go out into the field throughout the state.
You also talked about the Indiana Criminal Justice Institute funding this first piece. Have you talked to them about, and you said we are not, the study, we're not done. This is just a partial study. Is there talk about funding
A part two?
Follow up on the parts that didn't?
We have talked with them about that, and they seem fairly willing. What we have to do is design what that study might look like, and I guess I think it would be most appropriate that that would be informed by the thoughts of this body. You know, what do you think in the hierarchy of need is most important yet, that the information, the blanks that we need to know, and or maybe taking a slight pause and waiting for that next entity to organize and let them take ownership over what part two might look like. But I have some suggestions. I mean, I certainly have an idea of what else, where we want to go, and the social media emerging technology piece is at the forefront of my mind. But just as a legislator, I know our law needs that information. You know,
right.
we
I mean,
need
that probably is the quickest legislative fix with regard to prosecuting the victim in that.
Well, I was going to say, to back up a step, when I asked the court to appoint Deborah Daniels as the receiver, I said that we wanted to stand up in CASA so that it wasn't we weren't looking at what was the best way forward with one fully functional. I think the domestic violence team is excellent and everybody recognizes, but we had one that was in bankruptcy essentially. So the goal has been to create a fully functional in CASA so that we could take a serious look at what would be the best way in the future. And again, some states have found great success with merging the two, at least for administrative purposes, and have separate, or keeping them solely apart and maintaining the dual roles. So I know there's going to be a recommendation, but the goal that I had when I asked the court to step in and appoint was to have a functioning body so that we could continue, at least in a short interim, to make the decision. I think this group in the legislature is going to have to really take a look at what's the best way forward in the future.
Madam Chair. Thank you. Thank you both for your excellent work on this and being champions on this matter. I'm going to especially talk about Representative Hale, who's been a champion on this issue for a number of years now. So thank you for getting this report back to us. One of the things that you report here is the process of reporting is often not clear to students or teachers. And my question is, why is that? Is it because the law is not clear as to whom should report or who must report and to whom they should report? Is there something we can do to clarify that? It seems like that should be an easier process.
It should be. I think there are a variety of reasons for this. One is that it seems to vary from school to school and school system to school system. Some schools have a more organized structure and process for this than other schools do. And that could be for a whole host of reasons. It could be budgetary reasons, it could be attitude of the principal, it could be that they have a lot of other items they consider higher priority. And but nonetheless, there's a variety of those. And when I say other issues of higher priority, I don't want to suggest that bad behavior on the part of teachers, because they all want to help, but I also want to suggest that's part of the invisibility of the problem. They don't necessarily see it because we're not clubbing them over the head every day with these figures, and so nobody wants to think as they look out in their classroom there that there's both, you know, survivors and perpetrators. But I think the other thing is that you know, a lot of times in their school day, the teachers have so many things that they're accountable for, and they're rushed from here to here to this group and so forth. So how do you take the time out when you're supposed to be in this location instead of that location to go and tell somebody? Or when students sometimes they don't know who they can talk to or when's a good time to talk to them, how do they catch the teacher alone to talk to them? And so there's no particular identified best practice to teach people, to get people to learn it, to get people to know. And on top of that, even if we tell people once on the first day of orientation, that doesn't mean they remember in December when it happened. I can tell you as an educator, you're lucky if they remember it the next day, much less months later. And so, you know, and then if they don't know because of the nature of it, they don't go ask, because that's in effect suggesting there's a problem. And so it becomes compounded by that problem.
So to answer your question, there's a very clear procedure as to the reporting of abuse. And so that's, from my department, we certainly can put that out again. But teachers should be knowledgeable of how they are to go about reporting abuse. What happens is, what constitutes me reporting abuse? Do I have enough information from the little girl who came up and said that to go and report abuse? The answer would be no. So the point is when you go and report something, then something happens right after that. Something has to happen right after that. The principal has to go and report. Child Protection Services is things that go into place. So the person who's doing the reporting has an obligation to report, but you also have to make sure that you know what you're reporting might really be happening. So, because it's a very serious thing to go accuse somebody of doing something, or report something that's happening in a home, or report something that's happening. And so there's a very clear procedure for how that works in every school. But, it comes down to what is it that you actually have been told by the little child, or does that constitute me going and reporting an abuse? So it's human decision-making that enters the arena, really, is what happens. So what I don't think I see up there is the societal issue. I don't see a proactive approach to working with society in terms of what sexuality and relationships should be. And we were having a little conversation here. In Indiana, that's the purview, and supposed to be the purview of the parents, of the family. But more and more, it's not. It's the schools, as a result of the societal issues and the immense poverty and just the exasperation of what's happening within the society itself. So we can train us, and we can talk with kids. We have very clear restrictions on what it is that we can teach in our health classes regarding sexuality, regarding all of the topics, regarding the issues here. And you're right, teachers don't want to have kids in this kind of situation. No one does. But it's a much bigger issue than just training our teachers. It's a much bigger issue. And I don't know how to go about assisting with the actual issue. I've reported abuse myself as a teacher. So it's more and more commonplace. It's more and more commonplace for teachers to think something's happening to a child because of the following behaviors, even in the presentation that was before on the drug abuse. Some of the very same symptoms, a drop in grades, all the same kinds of symptoms. Something's going on, but is it something that I can report? Is it something that I can deal with? Is it something I have permission to talk with them about sexuality and relationships? Is it something that I can actually deal with parents? So it's a societal issue that I'm not sure we've got proactive things in place for recommendations.
Well, when they're talking about proactive, of course, they're talking about creating educational structure.
Correct.
Both for the students and the teachers.
And families. Families in general, from birth, and all the parenting skills and what is supposed to be a family unit. The family unit in Indiana isn't necessarily all intact, and we all have to get a grip with that, because it's not. We have so many different forms of family units now. Kids don't come equipped with a whole nice little family around them many times.
Just two quick pieces. One example is a teacher in a focus group said that a student came to this teacher and said that a friend told her that she had been sexually assaulted. But the teacher said, because of circumstances in our school and so forth, since I didn't directly hear it from the student, but I've heard it from, hearsay, so to speak. I didn't feel like I needed to report it. Now, that's one thing, but another thing is the teacher then equipped and even encouraged and trained to go talk to that student or get somebody else to talk to that student to find out? There's nothing clear about any of that and what's supposed to be done. Second is in the survey we find that almost half of the teachers, if a student does come and tell them, are not prepared to give them information to connect them to a therapist or to a forensic a nurse or something like that. And it's because, should they give that out? Should they not give it out? What are the consequences of giving out that information? That's not clear. And the second is that they get it for almost twice as often from female teachers as they do from male teachers. And again, we find that gender differential in terms of willingness to deal with the issue. And so I think, as has been said here, it's a complex problem that needs to. When I talk about education, schools are an obvious location because it's outside the family. That doesn't mean we don't need to educate families. It just means it can't be family only. And I agree that it should be done from the get-go. When the physicians we interview suggest we should be doing that as part of parental training, et cetera, even before they leave the hospital. And so there's a whole array of things that need to be looked at.
The bigger issue is where does this go? We talk about the education piece. This is an issue that affects so many of our Hoosier children that has no home. I was looking at Judge Bonaventura saying, well, you get the report. Is it something that your agency, you're a reactive agency, not a proactive agency. You look at INCASA with regard to having a 501c3 grant. But this issue doesn't have home. It's one of the biggest issues facing a number of our kids, and it's floating out there. So we can talk about, we should educate, you should do this, you should do that. There's just not a day as a judge. I haven't had cases involving molest. And most of the parents of Chin's cases I have, when you read their backgrounds and reports, they were sexually assaulted when they were young. So Representative Frizzell, your issue, it keeps just growing on itself. And it's ugly and it's horrific. I'd rather see a child with a broken arm than a child who'd been molested. But where's it going to land? So INCASA's a piece. I don't know. What are your thoughts? The reports come in your agency.
Right.
What do you think you can do?
Is there anybody of my staff present? Because they'll probably shoot me.
Jane, could you step outside for a minute?
They don't want to hear me volunteer us to do anything else, I'm sure. Honestly, just listening to it, it does seem like DCS is the logical place to house it for a variety of reasons. Because once it happens, it's reported to us. We probably don't have the infrastructure as we sit here today to make that happen. But I think if we go back and discuss who should really, be doing it, maybe we could repurpose some folks in central office to kind of do the research and look at the data and things like that.
Or work with other agencies.
Or work with other, whatever we have to do to get the job done. I'm willing to at least look at that to see if it's something that we could accomplish. It does seem logical that it goes with the Department of Child Services, thus the name. We're kind of about all kids. Right now, we are the reactive agency. We have to react when there's an issue of abuse and neglect, which just takes me 1 second. I want to ask comment on the superintendent's comments. I agree that teachers have so much on their plate because they're the ones that see the kid far more probably than most parents do in a given day, especially if the parents are working or absent or whatever. But I think that maybe it's not as difficult as it was described, because if you have a child that's reporting something's happened, I don't think it's anybody's place or responsibility, let me say, to try to find out the veracity of it. Is it true, and how are we going to prove it? So I think the discussion could be, something happened to me, and then report it. That's what the people in my agency are trained to try to discover. And I get we don't want to, lay blame on anybody's doorstep that is innocent. But I think that's a lot to ask teachers to do, is to not only be experts in educating children, but then to decide if abuse or neglect really did happen. That's the job of DCS. So I'm going to take that off their plate, to say that we'll do that investigation once the report's made, so that they don't have to go down that road.
Oh, I wasn't suggesting that in any kind of way, because teachers do not do that. But to even know if they should report what it is, that kids don't just come out and say, hey, very rarely, this happened to me. That doesn't happen as much as you think.
So we should talk. We talked about talking, because we have a whole educational video that helps teachers and others understand how and when they should report. so we'll talk about that.
And I would just like to, within this context, just remind us that there's a very practical problem in that most children don't realize that they're victims. You know, these things are happening, and now we know, you know, they're happening by someone they know, maybe very likely in their home. So this is awful and horrible, but it's normal, and it's their normal. So they don't realize that there's anything different, particularly in cases of incest or household cases of abuse. And yes, and I think that we do have an immediate issue in that when we teach human sexuality in our schools today, we have to teach abstinence. It's always abstinence. And I think that assumes that sexuality is always consensual, that someone has a choice. I have a choice to abstain. The message that isn't being put out there is that sometimes this sexual act is not your choice, so you can't choose to abstain. You know, this is something that's happened to you. I think in part of our curriculum, we need to be considering somehow, and I'm not a teacher, but somehow we need to find a way to make young people aware when we're talking about sexuality that this can happen against your will as well. And that message is not out there, because that might help when we do ask people to report and self-identify when something awful has happened.
Please go ahead.
Christina, yesterday I was at the Comfort House, which is one of 21 child advocacy centers. And when they bring children in, there's a video being done, and the professionals watch the conference, and they'll talk to the children and get them to report, you know, in their own way, to try to make an assessment. Now, how do we hook up DCS and the schools and everybody else to these people that are on the ground? I mean, there's 21 of them all over the states, and that's what they do for a living.
Well, DCS is involved with child advocacy centers. In fact, we fund some of that as well.
Okay.
So we are already with them, yeah.
All right,
I
never
can't
mind.
speak for the other agencies.
But I think the answer we're all coming up with is we have to synthesize all the people that need to be at the table, and perhaps through that new iteration of INCASA, if we're composing a new board, that the right people populate that board so that we're sharing the right information, and then if there are different duties, tactics, things that people need to take on, that we're all kind of part of the same strategy, and you know, might take a change in the law, it might take, you know, a number of things to happen, but the right people at the table owning it.
I think I just wanted to add that if we have the second highest rate, that means 48 states are doing better than us in some level. And also I've talked to some people at WHO about this, and there are some interesting programs in other countries. I don't want to suggest that I know all the solutions to this. That's not that there are a lot of people that work on this. But I do think that it would be a good idea to do some research on what are best practices, what are doable solutions in the context of the state of Indiana that we can find from elsewhere, to figure out how we can improve upon this problem, because clearly there are things going on out there elsewhere that are doing better than what we're doing, and we should know more about that before we start thinking about how we want to go about engaging in this. And I think if we do that in an informed way, we'll do all of our fellow citizens a favor.
Excellent. Thank you so much for taking the time to speak with us today. There's no doubt that this is a multifaceted issue. Additional research is going to be needed, as well as by the likes of a discussion. So we appreciate it.
Can you come back and let us know what happens with INCASA, what your next step is, if you're getting funding or not, what your needs are to the commission, and let just get hold of Danielle and myself and get on the executive committee agenda, and then we can bring proposals back to the commission.
Well, I'll take that as my recurring job, if that's okay.
You're hired.
All right, thank you. And I just want to thank this committee. Your time is precious, and you have so many heady issues before you, and I really appreciate you taking this seriously, your leadership.
Would you like to be the head of INCASA? Sorry. Did I say that out loud?
Thank you very much. Next on the agenda was the report on Cross Systems Youth Symposium. Don, if you don't mind, and if the other commission members agree with this, if we could table it for today and pick it up during the November meeting, is that agreeable to everyone? Want to make sure we've got enough time to dedicate to that?
There's also there's a lot of members on this committee that are on the Justice Reinvestment Committee that will go across the hall and have another 3-hour meeting.
Yes.
Thank you all for time.
So Don, we'll follow up. Thank you so much for being here today, and we'll make sure that you're on the agenda for next time.
All right, thank you.
All right, you're welcome. Moving now to the open discussion among commission members. Is there anything that any member would like to discuss or bring up today before we conclude? Yes. Oh,
No, sorry.
Superintendent
I just
Ritz.
want to say that at the last meeting that I said we were going to get a little subcommittee together to talk about the surveys that were happening in the schools and amongst the different departments. And I want to let you know that SEA 500 is on really appointed a committee to actually streamline the data collections and the surveys and things that we have within our schools. And so that will be a topic of that committee. So we won't have to have our own little task force amongst here. We'll let the SEA 500 committee deal with that.
Thank you for that update.
You're welcome.
And I just wanted
Judge.
to say one thing about, which I'm sure most people have seen either on the news or read newspapers, that Governor Pence authorized the Department of Child Services to hire 113 additional family case managers. As of close of business the very day, which was last Thursday, all 113 positions have been created. And we are in the process of identifying qualified candidates to fill those positions. And that was really done in response to a 26% increase in CHINS cases across the state. So I really appreciate the support from the legislature and the governor's office.
Absolutely. Thank you for sharing. Any other items for discussion today?
We have a couple of things we were charged with, legislating the baby box issue.
Mhm.
And so we've got things that are in the works that will be coming up on future. So if you saw that an item was assigned to this committee, we have the task force working on it first, and then they're going to be submitting their recommendations. They're doing a lot of hearings and legwork to bring it to us. So it's coming.
Absolutely. Mr. Landis.
Just to raise the issue that the 26% increase in the CHINS cases has caused a crisis in indigent defense systems because that is county-based. So when you add that burden, there's a right to counsel for those parents in those cases. The counties are struggling to try to figure out how to provide that representation, and we need help because that is an unfunded mandate on county government.
Thank you. Any other items? No? Well, our next meeting will be held on November 18th, 2015, here in Indiana Government Center South, Conference Room A. Look forward to seeing you all then, and with that, we are adjourned. Thank you.
you.